conditional probability, likelihood ratios, and the C statistic. Now, does that sound interesting or what? So for those of you who are hoping for information that will be in a multiple choice test on your boards, you might as well just take a nap, because you're not going to get any of that. What you're going to get is an understanding of how we use the rules of probability to make sense of data. And first, we're going to cover that from the perspective of understanding how we can use a diagnostic test to change our opinion about the likelihood of disease. It's a very upsetting topic. A lot of people get upset about this. It's very controversial, and if you're a Republican, you might as well just leave right now. But then we're going to talk about the C statistic, and what does C stand for? C statistic. Cool statistic, that's it. So let's go on. Why dice, other than they're pretty and they were in 3 colors? Because although statistics can't tell us the truth, statistics gives us a framework of talking about our experience according to rules, and the rules are derived from probability distributions that reflect the play of chance when there are multiple factors involved. So those who believe in mechanistic thinking often get frustrated with statistics because statistics always ask, how does this differ from a probability distribution where chance plays a role? But, and I can understand the frustration. Statistics can never tell us what is true. You can run anything through statistics. Statistics keeps us honest and makes us argue according to rules that we can all agree on. So, having said that, let's go to a common problem. So we can all participate on a voluntary basis, and Philip is going to be the first volunteer.
So 67 goes email text today. Hypertension, hyperlipidemia.
Yeah, hyperlipidemia.
Not yet tobacco. Left 2 months. She has sharp left fraternal chest pain. Mostly happens to climb stairs, but also goes to bed. It's gone for like a few minutes and might get better with time.
Or it might not.
I mean, not.
So what do you think? What is the probability that Mary has obstructive coronary disease? So we're not going to play with microvascular angina, and we're not going to play with this or that, or endothelial dysfunction. What is the chance that we take her to the cath lab and she has a 50% stenosis, a 70% stenosis, a stenosis with an FFR of 0.75?
So
whichever of those criteria you want to use as truth. And so intermediate means 50-50.
Yeah.
Okay. All right. So let's keep that in mind. And I interrupted. You were going to give a rationale.
No, it's fine. Because of her age, she gets some points in diabetes, and then the chest pain is atypical.
Yeah. So we would summarize this as age, 3 risk factors, atypical pain. So, but we want to make our reasoning more explicit. And we want to try to conform. You could tell I couldn't figure out the, whoa, back, you bastard. Okay. I couldn't figure out how to get the line to show up underneath. And the fellow wasn't very helpful. Where's Jeremy? Jeremy was not very helpful with this morning. So how do we picture the question? in terms of probability. And I thought that this Venn diagram is a good way to introduce this question, the question of how to deal with multiple probabilities. She has 3 risk factors, she has atypical symptoms, she's 57. Given that, what is the likelihood of heart disease? So this is how John Venn, that was Venn's first name, would have conceptualized this. He would have said that there's a population of all women. I could have made it all women, but I made it of all 57-year-old women. And then there are 2 subgroups. There's the group of women with coronary disease, and then there's a group of women with atypical pain and 3 risk factors, and they overlap. And in that overlap, we get a smaller group that have coronary disease. So not every woman with 3 risk factors and atypical chest pain has coronary artery disease. So instead of obstructive, I'm just going to say coronary artery disease. And there are some women with no risk factors who will have coronary disease. And, you know, I haven't drawn this in proportion, have I? Because this circle would have more women with coronary disease than this circle, and I haven't portrayed that accurately. But if I did draw them in proportion, then you could imagine that the area subsumed by these different divisions would correspond to the proportion of women affected. So the other way to think of this, and this may seem painfully obvious, is that we have smaller and smaller subgroups as we further divide this information. Now, how do we make the transition to calculations? So if we said that if we want to know the probability that Mary is a 57-year-old woman and Mary is a woman with 3 risk factors and atypical chest pain, given those facts, what is the probability of disease? We would express it as that what is the probability that she has 3 risk factors, plus what is the probability that if she has 3 risk factors, she has heart disease, the probability that she has atypical chest pain and heart disease, minus the probability that she has both chest pain and coronary disease. So that got a little muffled. So if the probability that Mary has 3 risk factors and atypical chest pain will be equal to, that's this, so 3 risk factors and atypical chest pain is equal to the probability that she has 3 risk factors and the probability that she has atypical chest pain Did I go the wrong way? Minus the probability that she has both 3 risk factors and atypical chest pain. So we can solve that equation for the goal of this is that if she has A and B, if you remember the Venn diagram, that was coronary artery disease. So the beauty of this is that we can solve for having coronary artery disease, given the other probabilities that we have. So we can reestablish it this way. We can rephrase it this way: the probability that she has coronary disease, given the probability that she has 3 risk factors and atypical chest pain, is the probability that she has coronary disease divided by the probability that she has 3 risk factors and atypical chest pain. Go ahead.
Probability of coefficient over the
No, it's not. There is no causation. So we say this is an observation. So we bring causation with our theories to this.
That's what we discussed. Does this probability explain the recovery from this chip?
They are related to each other, but in this case, the relationship is only mathematical. So if I observe that this proportion of people with atypical chest pain have coronary disease, then that is the probability of coronary disease in that group. And what we're doing is we are doing some clever math. Well, I don't want to spend a long time on this because you can go nuts. And we're gonna do a little bit more and then get rid of it. The point is that we can formalize and use rules in thinking about the conditions. So we can look at the probability of having coronary disease given these other things, but we are not making causal statements. So causation is a completely separate line of argument. So that's why the mechanistic people get mad with the mathematical manipulations, because there's no causation in the mathematical manipulation. But the statisticians never said there would be. They said that there would be a predictable relationship based on observation. The observations we make are going to be guided by what we think are causes. So, back to Mary. So Philip, you thought that Mary would have a 50% probability, but actually when I ran her through the Cleveland Clinic calculator, I got a 15% probability of coronary disease. And if you had used the ACC guideline, which uses the Diamond and Forrester model, it probably would have been closer to 30%. So, based on the 15%, we decide to get a stress test. It doesn't matter which stress test. But we'll say that the stress test we chose has a sensitivity of 90% and a specificity of 60%. So for the purposes of this exercise, whether it's a nuclear or an MRI, doesn't matter, not important. And these would be, you know, if you're a true believer, you might have gone for 80% or something like that. But I chose these numbers because they're easy to work with and easy to do arithmetic. So, caution, just refresh our memory. Sensitivity.
So the formula?
Well, how about the idea? You can give me the formula or the idea.
Two positives were the two positive electrons mix. So, in essence, given that a test is positive, is the likelihood that it's other expenses.
The ability of the
Its ability to rule out the disease.
I'm
No,
sorry,
it's not ruled in. It's ruled out the disease. Sensitivity is the ability to rule out the disease.
that's the classic teaching, right? That sensitivity, high sensitivity is a good rule out. But, and Jeremy?
It's the probability of a positive test given that you have the disease.
Right, so if we were thinking of the probability of A given B, we would say, what is the probability, given that you have coronary artery disease, what is the probability of a positive test?
I agree.
Good. All right. So, and then specificity?
The probability of something negative given the
Right. So both sensitivity and specificity assume that you know that disease is present or absent before you proceed. So the stress test is positive. So Ryan, what should this do for how should we now think about the likelihood, I shouldn't use that word, the probability of Mary having coronary artery disease?
Felt that, given her situation, she had a 30% chance.
We were working with 15 for the purposes of this exercise, but I mean, you could work with 30 if you wanted to, but all the other slides will use 15.
Yeah, so on our scale of 0 to 100, we're at 15. Now we have a test that was positive. So looking at our curve that goes up like this, we have new pretest probability combining what we have. A new post-test probability, which becomes our new pretest probability, which we decide to do for the test.
All of that is true, but you haven't answered the question. but that was, well done.
All right. The simple answer is it's Catholic.
That is the simple answer. We're right. The test was positive, and the test seems to have reasonable parameters. So we think that the probability is going up. How much? How much should this test make us revise our pretest probability? 6%?
The lower the pretest probability, the less your testing positive is going to affect your post-test probability. Like, only do a stress test if it's really probability to get one.
Right. Now, unfortunately, so I agree with everything you said, and that's an important point. But it turns out that the ESC will give intermediate probability of 15%, and the ACC 10%. They are not. So basically, everybody is intermediate risk in our world. So, but you are correct, and I do want to make it. I agree with the implication that stress tests have little to offer at the extremes of probability, and those arbitrary definitions from ACC aside, she's wrong. So we're not going to learn much. But the other part of your message is also important, and I want to emphasize it, that we can only interpret sensitivity and specificity in terms of disease prevalence when we're trying to decide how likely disease is for an individual. So let's think about this, and let's try to get be more thorough, or to be more quantified, to quantify this better. Let's step back before we do that and talk about Bayes' rule. So we've already talked about conditional probability, and we've said that the probability of Mary having a positive test, given that she has coronary disease, is the probability that Mary has a positive test times the probability that she has coronary disease divided by the probability that she'll have a positive test. So the likelihood of having a positive test is dependent on having coronary disease. And the more we think that she has coronary disease, the more she's likely to have the positive test. You know, when you put it that way, it just sounds obvious. And this is an axiom from conditional probability. So Bayes' rule is a clever variation, and I'm not going to derive Bayes' rule. If you're interested, I can send you the derivation for Bayes' rule. based on two definitions. It's not a theory. It doesn't explain anything. It is a deduction from basic axioms of conditional probability. So to adapt Bayes' rule and conditional probability to clinical work, or scientific work, we simply say, instead of A given B, we'll now say the probability of the hypothesis given the evidence. So the hypothesis might be that Mary has coronary disease, and the evidence could be that she has 3 risk factors, or the evidence could be she has atypical chest pain. Or we could add the probabilities from those two, or the stress test. Now, if we're going to think about what the beauty of Bayes' rule is, that we have to think of total probability. So the total probability means that if something might happen, it might also not happen. So we might say that the hypothesis might be true, or the hypothesis might be false, and we might look at the false hypothesis. We might look at the lack of truth of that hypothesis as a second hypothesis. So if we look at the probability of something happening or something not happening, and we add them, then we have the total probability. So it might rain tomorrow, but it might not rain tomorrow, and the total probability is the probability that it will rain or not rain. So when we put those together, we have Bayes' rule. So I hope this will become more obvious as we get back to our specific instance. So the probability that Mary has coronary disease, that's our hypothesis, given the positive stress test, that's our evidence, is the probability that Mary has coronary disease times the probability of a positive stress test given that she has coronary disease. What is that? That's our sensitivity. So that's how sensitivity and specificity tie in with conditional probability to making, not specificity, but we'll come to specificity. Ties in with conditional probability and a structured argument about whether Mary has coronary disease. Divided by the probability that Mary has coronary disease. This sounds familiar, doesn't it? Because it's a repeat. So divided by the probability that Mary has coronary disease and that she has a positive stress test, given that she has coronary disease, plus the probability that Mary does not have coronary disease, given that she has a positive stress test. In other words, what is this sentence? Specificity. So the stress test may mislead us. It's 1 minus specificity. Correct. It's 1 minus specificity. It's the false positive rate. So we can think, 1 minus specificity is the false positive rate. Sensitivity you can think of as the true positive rate. Rate of what? Rate of positive effect. So we've already answered this question. Sensitivity and specificity, these are just dreadful screens. Remind me not to hit them. Phew, that was hard. Yeah, don't touch the screen. All right, so the point is that we can relate sensitivity and specificity, or 1 minus specificity. It doesn't really matter, right? They're inverse of each other. We can relate that to the probabilities. Now, we still haven't figured out how to quantify the information we got from the stress test. So let's proceed and do that. So our pretest probability that Mary has coronary artery disease is 15%. And how did we get that? In a way, that was our first test, although in that case, we got it from the prediction rule. but you could get it from, you could get it from intuition, which is what we have to do in the office. You could get it from prevalence data, but you get it one way or the other. So that is our pre-test probability. And then the question is, what is our post-test probability in light of the positive stress test? So we've, in a way, we've covered this a little bit. If we talked about how Bayes' rule is going to tie together the post-test probability, the pre-test probability, and the results of the stress test. So to put that more simply, if we do a little bit of algebra with Bayes' rule, we can restate Bayes' rule as saying that the pre-test probability is, the post-test probability, so the probability of coronary disease, is the pre-test probability, which was the result, the likelihood, this is related to the prevalence of disease, times the sensitivity divided by 1 minus the specificity, or the true positive rate divided by the false positive rate. And this is the likelihood ratio. And that's the definition of likelihood. So you knew that, and that's great. The reason I've avoided using the word likelihood up to now is that this is a special use of the word likelihood, which was invented by Ronald Fisher. But the idea was thought of. I don't know if you invent ideas, but you thought of the idea. And it's a little troublesome because likelihood in common speech means probability. It's really a synonym. But here, it really refers specifically to the ratio of sensitivity over 1 minus specificity. And what does this do? It's a multiplier that lets us see how much that stress test, or any test, can change our opinion. That ratio is the power of the stress test to change our minds about probability. Change it from what? Well, you know, that depends on what we thought it was to begin with.
So, in the equation, how does it change whether the test is positive or negative? So, this is assuming that the test is positive, you're supposed to test that, right?
Yes, so we would have to work through a series of, shall we say, parallel mirror image equations for negative tests, a negative likelihood ratio. You can do a negative likelihood ratio. This is a positive likelihood ratio. I couldn't, to be honest, I wrote this talk Monday and Tuesday night, and there was no way I was going to get that done. So, but yes. You can kind of do the inverse of this. So for Mary, the pretest probability was 15%. And this gets back to what you were saying, that we have to have some idea of the prevalence. So pretest could mean prevalence in this case. And then we need to get the ratio of the sensitivity and specificity. Well, the sensitivity is 90% or 0.9. So in probability, 0 means something can never happen, and 1 means it must happen. And a fraction between 0 and 1 is our estimate of how likely that event is. So 0.9 divided by 0.6, and and that gives us an odds of 0.18. So let me back up. So this is a detail. This is not important. But when we look at sensitivity divided by 1 minus specificity, we end up with an odds ratio. The chances that something is, or the chance that something is not. Now that's an odds ratio. So if I'm
if I'm going to choose 2 out of the 4 of you in this row, then the odds are 2 versus to 2. But there's a 50% probability. So the chance of them being chosen or not being chosen, that's an odds ratio. The likelihood or the probability that of being chosen out of the entire group, that's a probability. It's the chance of being chosen out of the entire group. So we end up with an odds ratio, and then whoever does that, nobody. So then we convert it back to a probability, and we have 20% when we do the arithmetic. So the positive stress test with a sensitivity of 90% and a specificity of 60%, which, by the way, is not that far from where no stress test plays, has changed our opinion about the likelihood of coronary disease from 15 to 20%. So the likelihood ratio is one way to say that we have learned from experience. The experience is observing the results of the stress test.
Oh, I think, should be 0.9 divided by 0.9 divided by 0.4.
It should be.
33%.
I made a mistake. Yeah. Thank you.
I would never.
No.
It's 1 minus, yes, it's specificity with 60, so.
Yeah, you're right. So I'll fix that the next time around.
40%.
Yeah. So the post-test odds are 40%. Okay. Yeah, so 40%. So actually that's quite a bit. So from 15 to 40%, but it hasn't brought us certainty. So there's a big change, but we may or may not decide that that's clinically helpful.
So you're saying we should get stress MRIs on?
Yeah, I don't know. You know, it wouldn't change that much. Yeah. So if you have someone, as a rule to remember, if you have somebody at the extreme, then the stress test might get you into the middle range, but it won't get you into the high end of the range. All right, so now Mary asks about her stress test. And we say that it showed inferior hypokinesis. Then we remember, that's not right. It showed anterior dyskinesis and inferior akinesis. Mary asks, well, so what? They're both abnormal. Would it make any difference in the probability of disease if the result was one or the other? So, do you think it would? How so?
Well, that's on the that's abnormal. There is a chance that it's a false positive, or less severe, but if it's more severe form, chance that the test is positive, and actually shows disease is also higher, so that should increase your post as well. It's going to be more. So
can you put that in terms of sensitivity and
specificity?
That's
well,
you can.
so okay,
You
so the chance that it's a false positive is more. So that means it's more specific. It's more.
Which one is more?
The one with more disease or more abnormality.
Okay, but we want to think about total probability. So which one is more sensitive?
The first one would be more sensitive.
So inferior hypokinesis would be more sensitive, but would have a lower specificity and a higher false positive rate. And multiple areas of akinesis would have a high specificity. There'd be fewer false positives, but it would be less sensitive. So we could express that in likelihood ratios, and I've just arbitrarily chosen a sensitivity of 0.95 and a false positive rate of, this should really be 1.2. I'm sorry, 0.2. And likewise for anterior dyskinesis and inferior akinesis, the sensitivity is lower. I wish I'd stopped doing that. But the specificity is higher. So the point of this exercise is that most diagnostic tests can be interpreted at different thresholds for the disease. And the threshold you choose will determine the sensitivity and specificity you observe. So it's in a way, it is a simplification to say a positive stress test, a positive VQ scan, a positive whatever it is. I mean, if you can think of any test where really there is a division that is always for all patients clear cut, as opposed to gradations in different groups, and gradations according to how severe it is. A BNP of 450 as opposed to 4,000. So how are we going to cope with this problem about multiple thresholds of the test? So we're going to use the receiver operating curve and the C statistics. So you knew this was the last part of the lecture. So why is it called the receiver operating curve? Radar. In World War II, radar operators received blips on the screen, and they had to figure out if it was noise or an enemy aircraft. And they needed some criteria by which to notify the defense forces that incoming airplanes were arriving.
So this was after Pearl Harbor, I'm assuming?
I don't know. Now, the likelihood ratio is very much linked to the receiver operating curve. The receiver operating curve gives us a series of likelihood ratios over the span of all imaginable sensitivities and specificities. By the way, all imaginable means 0 to 100, because 0, it can never happen. 100, it must happen. 100 is nirvana. 0 and 100 are nirvana. We are certain. We are God. Everything else in between is human. We know that. But we can estimate the chances. So on the x-axis, we have 1 minus specificity. On the y-axis, we have sensitivity. Or you can think of it as the true positive rate divided by the false positive rate. So a test in which the true positive rate and the false positive rate ratio is 1 would be a straight line connecting 0 and 1. So that would be a test with an area under the curve. If we look at the area of this rectangle, it's not a curve, the area under the straight line would be 0.5 of the whole. That test would be as good as flipping a coin, and if we could figure out how to build for that, that would be really cool. But most tests will have a curve And here I put a star and the numbers 40 and 83. So 20, 40, 60, 80. I didn't touch the screen this time. And then 20, 40, 60, 80, and it's a little bit higher. So how would you put into words what 40 and 83 mean? One minus the specificity, so 1 minus 60 is 40. So we're looking at a false, the specificity of the test was 60%, the false positive rate was 40%. And then the 83, sensitivity. So these are matched pairs. Each point is a matched pair of sensitivity and 1 minus the specificity. So this answers the question, how are we going to judge the sensitivity and specificity of a diagnostic test when we can interpret the diagnostic test in multiple different ways with different sensitivities and specificities? This will pair the sensitivities and specificities. It also shows us the trade-off. We can be more sensitive, we can be more specific. Which is more important? Sensitivity or specificity?
Depends on for a patient or a lawyer.
Yeah, it depends whether you're more worried about missing disease or more worried about falsely labeling. There is no right answer. Usually we'll choose something in the middle somewhere. Now, one other question about this. When was the last time you ordered a test with a known sensitivity of 10% or a known specificity of 10%? Where did they get that information from to draw this curve? This curve obviously is made up. It's extrapolated. Yeah, there is no such information. So most of the curve is actually not derived from observation, but from matching a probability curve to a restricted area of sensitivity and specificity.
Mostly the 0.5 to 0.8 range or behind with the majority of our specificity and sensitivity, so that's kind of where we just extrapolate.
Yeah, and I have to admit I'm not an expert on this. So now, we talked about how sensitivity and specificity vary with the threshold of the diagnostic test. But sensitivity and specificity are also going to be affected by the standard we compare it to. So here, a calcium score was compared to a 50% stenosis on invasive angiography and a 70% stenosis. And the area under the curve is not surprisingly larger. 0.75 doesn't sound like it's a lot bigger than 0.7, but it's very hard to make these. The area under the curve is not very sensitive for these distinctions. So a difference of 0.5 would make the authors ecstatic with happiness or some other things, depending on what they're doing. The area under the curve is a one number summary of how good the test is. So if you look at all the combinations of sensitivity and 1 minus specificity to summarize the accuracy of all those different calculations, we look at the area under the curve. And the higher the area, the closer the curve is to the left upper corner, the better the test. And the area under the curve is also called the C statistic, and C stands for concordance. Concordance with what? It's because the area under the curve and the receiver operating curve has been used to look at the goodness of fit of models, then the concordance is between the model and the observed status. So C statistic is really just a synonym for the area under the curve. All right. Mary learns that her stress test was positive. We already covered that, right? We told her that. We sort of forgot whether it was hypokinesis or anterior kinesis. We said, Mary, cut it. And that the area under the curve for her stress test was 59%. And I just pulled this from an article which happened to be looking at ischemia in the right coronary artery territory, but it doesn't matter. It could be 60%, could be 70%. She asks what that means for her in plain American English, not English. How do we explain that 59% number to her in terms of her chance for disease? Does this have any meaning? Or what does the 59% mean? So the area under the curve is 59%. It's a measure of the overall accuracy of the diagnostic test we ordered. Yeah, well, it's a disappointing result.
It's low, it's very low, but it means that this test will capture 59% individuals who have true disease. We have more than we have years.
No, I think it just means that the 9% of it basically tells you about the accuracy. So there is a 59% of chance that whatever the test says is true.
That's why
I know it's the C statistic. Yeah, we're still on C. We haven't gotten to D or any of the other more advanced levels.
No, the Z score, oh my God.
No, I don't think we can that, because this is 0.5, and
0.59, but 0.7. It doesn't matter.
So, this perfect.
But just put the meaning of it into words.
Any words that have this test, times, and then.
Well, 6 out of 10 have disease, but having this is possible.
Say that one more time, Shadi. I get confused too. No, seriously. I mean, these probability statements, the conditional probability. So, if she has a positive test, or if she has
the disease,
then that's correct.
one chapter.
That's exactly what it is. So it's a restate. It's much closer to sensitivity. We really can't say anything about Mary's probability of having disease. We didn't have the area under the curve had nothing to do with that. Just as sensitivity and specificity have nothing to do with that, without knowing the prevalence. So of people, if Mary has coronary disease, there is a 59% chance that she will be correctly classified as high risk with a positive test. That's the meaning of the area under the curve. It's a classification. It's a discrimination. So what is discrimination versus, I'm getting ahead of my slides. This is terrible, ahead of my slides.
What happens if she has a test twice?
Well, that has to do with reproducibility. You can actually use Bayes' rule for a series of probabilities and calculate what the probability is. So you would actually change the probability. And if you repeated the test several times, it's not that the test is useless. You would just have to calculate what the probability would be after those variations. Yeah.
yeah, can you verbally say the difference between
So, sure, because they're similar. So sensitivity is of people with disease, or given that you have the disease, what is the likelihood that you will have, what is the probability that you'll have an abnormal effect? The C statistic we'll get into. So it's going to be that plus something else. because the C statistic is sensitivity divided by 1 minus specificity. So hold that thought about sensitivity, and we will elaborate its difference with the C statistic in words in a moment. So what do we need? We may have answered this question. What do we need to add to the area under the curve to get to Mary's probability of disease? So you have 3 choices here. So the prevalence of disease in the population to which Mary belongs, would that work? The probability or the pretest probability or odds of coronary disease before the test was performed, or the predictive accuracy of the test. Actually, they're restatements of the same thing. Yep. So if one is correct, 2 must be correct. What about 3? What is 3? Who could put predictive accuracy into words? Yes, probably. Okay, probably predictive value.
The probability that the test will be positive if actually if the test is positive, maybe you study.
What is the probability that she has coronary disease given that she has a positive test? So that's the question we ask in the office. We don't know if Mary has coronary disease when she comes to pre-operative. We may know her insurance status, but we don't know if she has coronary artery disease. So the predictive accuracy is affected by prevalence. So these are all 3 linked. The predictive accuracy is influenced by prevalence. So it's in here, but indirectly. These 2 statements deal directly with pretest probability, which we take to be prevalence in that population. So prevalence is not quite the same thing as pretest probability. We are using it as our pretest probability. I still haven't forgotten about your question. And if we don't get to it in the next 2 slides, then I'll come back to it. I think it's in there. So let's talk about some problems with the receiver operating curve. We already talked about one issue, which is that the receiver operating curves will look different depending on the standard of truth that you use to judge your diagnostic test on. So you can change what appears to be the sensitivity and specificity by using a fractional flow reserve of 0.75 or 0.8, or in our lab, 0.83. Now, let's talk about another problem. We already mentioned that the extremes of the curve are sort of made up. They're not made up, they're extrapolated, which to me is the same thing since I can't be arithmetic. Here, the authors of a paper highlighted the area under the curve between a sensitivity of 70 and 80%. But the curves are different shapes. So there's no rule that says all diagnostic tests have to have the same ratio of sensitivity to specificity at a given sensitivity. Which of these diagnostic tests, which have the same area under the curve, close enough, 0.11, 0.12, don't. So the goodness of fit, the goodness of the test overall from 0 to 100 is the same. But in the range of 70 to 80% sensitivity, and are we ever really going to be interested in a test with a sensitivity less than 70%? We're getting perilously close to tossing a coin. We have a much different result. So which of these would you prefer? Well, no, because the sensitivity is the same. Both have a sensitivity, this sensitivity is the same as this sensitivity. So your chances of missing disease are the same. So this one, so the false positive rate here is 20%. The false positive rate here is 50%. So it doesn't matter to us that the area under the curve is the same, because in the region of the receiver operating curve where we are interested in testing patients, one test has much better characteristics than the other. So the C statistic is a very gross statistic, and by itself may not be a good guide to the clinical utility of a test. Now, why don't we simply report C statistics, partial C statistics between 30 and 70. By the way, that's the usual range I'm sorry, that's not what I meant to say. Between, say, 70 and 90 sensitivity. Why don't we simply restrict our C statistic? And the answer is that when people have tried to do this, the receiver operating curve for two tests tends to be extremely variable, and slight changes in the definition of what constitutes a positive test can result in reversing of the order of which test is better. So probably we're dealing with small numbers and a small range and getting too much variability.
How many calculators you can under the curve? Is it just the area that you're highlighting?
It's in the dark gray.
Only the dark
Yeah.
area?
Yeah. So we're talking about the area under the curve, but just between 70 and 80%. So it's between these two dotted lines. So, right. So the box is the same. The problem is the size of this rectangle is the same. It's almost a rectangle, whatever that is.
Got it.
But this rectangle is shifted over into a more desirable position. All right, thank you. So somehow I got this wrong. So your question was, how does sensitivity differ from the area of the C statistic? And the answer is that the C statistic is more complete. So the sensitivity asks, given that you have disease, what is the probability that you have a positive test? And the C statistic will add to that, given that you have disease, what is the chance of a false positive test? And it wraps that into one number. So I'm going to end the lecture here, and I have some summary slides if you want them, or we can skip them. But I do want to, before I end, I do want to say that I'm focused on receiver operating curves and likelihood ratios for diagnostic tests. But they are also used for prediction rules and to judge the adequacy of prediction rules and for other prognostic reasons. And there are many problems with the receiver operating curve in that area too, but that would be a whole nother lecture. So rather than summarizing, or going through the summary slides, and you can get them all from Elizabeth, I would say that what I tried to do is show you how conditional probability and Bayes' rule, in an intuitive sense, can help us learn from experience by showing us how we can update our probability given new information. And then to deal with the problem of the variability and how we interpret our tests, we can use a receiver operating curve, although we have to be careful when we do that because of the pitfalls of the receiver operating curve. And we should know what the value of the receiver operating curve answer is in the range of the sensitivity we're interested in, rather than relying on the specific as the only measure of whether it's reliable.
Oh, good, I don't even have to clean up.
How long did it take you to wrap your head around the?
Oh, one time I missed that arithmetic.
I didn't call you on that.
That was great.
I calculated.
More likely to get. Well, they have the difference. They have this thing. And then
Listen, you should look at 5% over doing that.
Right.
Me too.
Nancy too.
Oh, yes.
Yeah.
Make sure you say hi to them.
I will. Random, so random. First I heard from him, hard to.
No, yeah, I wonder that every time.
Thanks for doing this, Mac.
Oh, no.
What they could.
Or that, yeah.
Yeah.
Honestly, though, I think this is probably more pertinent for,
People are tired though. I should have taken that earlier hour.
oh,
Because it would be a witching one. Can I use my laptop?
Yep, laptop or USB, whatever you prefer.
USB.
Yeah, I do the same way here. I'll put it right here.
I have a slide mover. My battery is always finicky, so I'll run it.
Hold on.
Yeah, you might need that.
The dongle.
Yeah. Usually have one.
The other, I'm just trying to think.
Yeah, you'll need that connector. But I know you guys probably have it, because a lot of your guys use Mac.
Yeah, we do. We just have the.
Hey, who's got anyone have a? Oh, nice. Very nice.
And by the way,
Beautiful. Beautiful. Found something?
Yes. No, that's what we need,
But it
though.
depends on who wants to watch.
No, I.
A well-informed audience too.
That's what I think. The more in depth, the better for. Oh yeah.
Some inappropriate stuff.
I would.
It's an Indian chief.
Yeah.
I wish I could
buy the real thing
I'm sure it's not cheap.
someday.
So we've been in the lab, and, 3 or 4 animals a day this week. Pretty good. At your own personal.
Yeah. What time do you guys stop doing this thing?
So we have a lecture, your lecture, and then about a 15-minute break, and then Bill is giving a talk.
Okay.
Bill is giving a case from.
Sure. Do you have a temperature control? The room is totally.
So you're there, you're at all 3.
Sure. I was just gonna ask, do you have a temperature? I'm sure Dr. Sakaguchi will.
Yeah.
All right, guys. For those, pretty much everyone here has probably met Dr. Mbai, one of the staff cardiologists at the VA. He's going to give us a talk on NOACs. I think this is a question, it's a broad topic with a lot of data, but it's something that we really haven't had to talk about in a long time, and it's directly applicable to pretty much all of our practices. So I think it's a good opportunity to try to cover a broad and get as deep in the weeds as possible on important topics. All right, thank you.
Sure, thanks. Who's comfortable with NOACs? This is a well-informed audience, so I need to be on top of things and keep me honest.
Yeah.
What was that?
It says some of them more than others.
Okay. Does anyone have a preferred NOAC? I heard Xarelto, that's a trade name, Bill. Rivaroxaban. Why Rivaroxaban? So you're using your compliance, patient compliance as your, okay, fair enough. So who thinks that you can have a Hazlitt score that's too high and that contraindicates anticoagulation? So is there a time where your bleeding risk exceeds your prevention of stroke or thromboembolism? Is there any evidence basis for that? Oh.
Usually your head blood tracks your chest, do that for.
Good point. Well, we'll probably go over that.
The most severe, that was one today.
Okay, good. We'll discuss that some more. So just think about those questions. And in the very elderly, aspirin and clopidogrel are good options to mitigate bleeding risk as opposed to warfarin. I hear no, no. Okay. Fair enough. What about aspirin and clopidogrel versus aspirin?
More leading with clopidogrel for the prevention.
No, aspirin, clopidogrel together versus aspirin alone. Okay, so fair enough.
I think GI bleeding is increased with that combination.
So this is a well-informed audience. We'll get into the weeds. Keep me honest. I have a lot of material to make it worth your while. Otherwise, this will be an internal medicine talk. So many of you have probably seen this slide. If you've not, it's put together by John Cam. He was a lead author of the European Society of Guidelines in 2010. It's a fairly good summary of contemporary management of atrial fibrillation. It has everything there. I personally like it. It shows that upstream therapy of concomitant or situational factors is probably your priority when you see a patient with AFib. Oftentimes when you do an internal medicine consult, internists get frustrated when you tell them to treat the underlying cause. But in reality it is. The light blue boxes indicate treatment of conditions that change patient outcomes. The gray box, rate control, preventing attack-induced cardiomyopathy, may change patient outcomes. Doesn't always, if a patient has an underlying cardiomyopathy. What's in red is symptom control, and that's what electrophysiologists tend to do. Oftentimes when you get a consult, they want one of these, and oftentimes people don't focus on these. Previous iterations of this figure had antithrombotic therapy as opposed to anticoagulation. I think this has evolved to nice anticoagulation. And I think in the future, this will probably change. It'll become prevention of thromboembolism because not just anticoagulation, there's mechanical devices that are coming online, okay? So I've shown this slide. Some of you have heard this talk, some have not. Who is this? Wise person says C.M. Fisher. Charles Miller Fisher is a Canadian. He was born in Waterloo, Ontario in the last century and was one of 9 kids. His mother died when he was age 11 at childbirth, and he went on to school there and ended up at the University of Toronto, where he went to medical school. By the time he graduated medical school, he married his college sweetheart, and World War II broke out. Canada wasn't part of World War II when he graduated. So most Canadians who volunteered were assigned to the British forces. So he was assigned to work on a merchant ship, HMS Voltaire, with the British Navy. They went out in the Atlantic, and during his first year of tour, they encountered a German cruiser. German cruisers were non-combatant, or German ships disguised as non-combatant ships, and they tended to fly flags of other countries. This particular ship flew the flag of Greece, and it would get close to an Allied ship and change its flag and start firing. The German cruiser was Thor, and Thor had had 2 previous unsuccessful battles. There's a lot written about this German cruiser Thor. Anyhow, during the battle, they managed to sink the HMS Voltaire. 1/3 of the sailors on HMS Voltaire died. The rest jumped overboard because they couldn't launch their safety raft, and the Germans rescued the majority of them. Many of them had been in the water for 6 hours, including C.M. Fisher. So pretty much from 1940 till the end of the war, he was a prisoner of war. He tended to some of his colleagues in prison camp, and during that time he became very fluent in German and also took meticulous notes. He was a sort of a detailed-oriented individual, took meticulous notes of their conditions. After the war, he went back to Toronto, went to postgraduate training, became a neurologist, and moved to Boston. While in Boston is when he wrote to the Lancet, and this was one of his observations. Well, C.M. Fisher is the same person who described TIA, transient ischemic attacks. He described lacunar strokes. He founded the stroke service at Mass General. He is regarded as a preeminent neurologist of the last century. And he made this observation in 1972, that all patients with chronic atrial fibrillation should be considered for prophylactic anticoagulant to avoid a fate worse than death itself. What's the fate worse than death itself? It's stroke. So let's go over some of the stroke facts. Not all AFib is associated with stroke, but in this country, this is data from CDC and the National Institute of Neurological Diseases. About 800,000 people have a stroke, 130,000 deaths from stroke. They account for about 1 in 20 of all deaths. Stroke is a leading cause of disability, and 87% of all strokes are ischemic. AFib is important because you have a rise in the number of patients with AFib. This is a figure out of Mass General, and they use a projection model to come up and try and predict in the out years the numbers of AFib patients. At present, it's about between 5 and 6 million. The green line is if you don't have increase in incidence. The blue line is if you have increase in incidence. So this is a worst case scenario. This is if we stay on the same trajectory. So going out to 2030, that's 9 million patients with AFib or 12 million patients with AFib. Problem with AFib is, unlike other strokes, the majority of strokes with AFib are disabling strokes. They lead to profound disability, nursing home, care providers. This is a figure from Hart et al. While he was at the University of Texas. That shows the different categories of AFib. You have in the dark bars, high risk, CHADS score back then, greater than 3. In the gray box is the intermediate risk, and the white box is low risk. And you see the majority are ischemic strokes, no surprise. But in the patients who are high risk, over 70% have disabling strokes. The ones who are at intermediate risk, about 67% have disabling strokes. In low risk patients, the disabling stroke rate is not that low either, it's about 33%. This is important because preventing stroke is an important aspect of managing atrial fibrillation. And the disability from atrial fibrillation really is a public health problem. So how well are we doing? Anyone know what percentage of patients eligible for anticoagulation in this country get some kind of antithrombotic therapy? So it's probably higher for antithrombotic. What about anticoagulation? These are not synonyms. It's about 50%. And these are older numbers. So we have data from our neighbors up north, the Canadians. So the Canadian Stroke Network did a prospective audit. They looked at 12 stroke centers in Ontario from 2003 to 2007. And the patient had to have one of these factors. They had to have had known atrial fibrillation, be classified as high risk, which is just one CHADS risk score. And they have to have had no known contraindications to anticoagulation. And these are patients presenting with stroke with known AFib. And this is what they found. High risk, one risk factor, CHADS. Of those patients with known AF presenting in stroke, only 10% were on therapeutic warfarin. Less than 50% were on warfarin. Well, someone will say CHADS 1 will accept that. These are very high-risk patients, patients who had had a previous stroke. And you can see only 18% were therapeutic with INR. So the goal of care is not to start warfarin. The goal of care is to get the patient therapeutic on warfarin. Why is this important? With the newer agents, if you have fixed dose regimens, you can get patients therapeutic and hopefully not have this kind of problem. But we'll address why you can still do better with warfarin. American numbers are not much better than this. I don't think we have an audit for this. So we'll go over the evidence today, and there's a lot of material. We'll look at aspirin, we'll look at aspirin and clopidogrel, we'll look at warfarin, and then we will look at the newer agents. If we have time, I'll go over a couple of slides and look at the occlusion procedures. This is not small because I think little of them, it's because there's no time, and I'm sure an EP doc can go over that with you. Throughout the rest of the hour, I want you to think about every therapy within this framework. Efficacy, which is prevention of thromboembolism. Safety, which is bleeding, particularly intracranial hemorrhage, which is particularly disabling. And then with every therapy, there's a net clinical benefit, and the goal is to have a positive net clinical benefit. Reduction of stroke should be greater than the bleeding risk, no matter what. So aspirin. This is a dynamic slide. It's changed quite a bit. I've given this talk previously, and I had a same authors, same meta-analysis, 1999. They put a second one out in 2007. They seem to put one out every 7 to 8 years, so they're probably due to put one now. They looked at all aspirin trials where it was aspirin versus no treatment or placebo. 2007 numbers are different, and I'll show them to you in a little bit. 7 trials, aspirin, placebo. They had about 4,000 participants, about 400 strokes. They wanted to test the effect of aspirin, so they tried to rid themselves of the trials that had mixed antiplatelet therapies. So of the patient population, 90% during that follow-up period had had exposure to aspirin. The aspirin dose was variable from 81 milligrams to 1,400 milligrams for aspirin. The trials pooled together showed a trend towards reduced stroke. But aspirin reduced incidence of stroke by just 22%. It's a very modest decrease, and we'll see other numbers. The absolute risk reduction, this is primary prevention, was 0.8%. Number needed to treat, 125. This figure will evolve in a little bit. This is secondary prevention. Number needed to treat was 40, but the absolute risk reduction was only 2.5%. So pretty minuscule numbers. In the primary prevention cohort, the stroke event rate was only 5.4%. So you knock off 0.8% and still about 4%. Go ahead.
For first year diagnosis or overall follow-up?
Overall.
Okay.
The only study that was statistically significant was the SPAF1 trial that looked at aspirin 325 versus placebo. So if you come across guidelines that recommend aspirin 325, I think this is the basis for that. Why wouldn't more aspirin have beneficial effects? It's that net clinical benefit. The higher doses of aspirin, more bleeding, they mitigate the positive effect of prevention of stroke or thromboembolism. So this is the active A trial, which was aspirin, clopidogrel versus aspirin. It was published in the New England Journal of Medicine by Salim Yusuf's group and McMaster. And as you can see, with regard to the primary outcome, stroke, MI, systemic embolism, or vascular death, clopidogrel and aspirin outperformed aspirin. But the absolute risk reduction, again, was minuscule. The event rate was 7.6% per year with aspirin. Clopidogrel, 6.8. So, Chadi, I should probably reverse myself on the earlier slide. So the absolute risk reduction was just about 1%. But look at the bleeding events. Clopidogrel and aspirin, 2%. Aspirin, 1%. You basically traded one stroke prevention for one bleed. Problem is, look at fatal bleeding. Look at major bleeding. So you essentially doubled your patient's bleeding risk for a very small absolute risk reduction in their stroke event rate. What about aspirin, clopidogrel plus warfarin? Someone talked about this a little bit earlier. I think it was Matt. This was the active W trial. They randomized 6,000 patients, same primary endpoint. Warfarin outperformed clopidogrel and aspirin. the study was, I think, stopped prematurely. What about in the very elderly? Warfarin as a therapy. The Birmingham atrial fibrillation trial, this is Birmingham, UK, not Birmingham, Alabama, randomized about 900 patients. They were mostly octogenarians to aspirin versus warfarin. They had a CHAD score that was just 1 to 2 for the majority, but a little bit more than a quarter had CHAD scores of 3 to 6. Stroke event rate was much lower in the warfarin group. This study was also stopped early, prematurely. Look at MRI, ischemic stroke, total number of events. The Danish AFib cohort study is a registry study from Denmark. Denmark is a country of about 4.5 million people. They have a nationalized health service. So everybody in Denmark goes to pretty much the same health service. They have a pretty accurate registry of patients. So in Denmark, if you want to find out what particular therapy a patient had, it's pretty easy to identify because there are no other providers. Sweden is pretty similar, and we'll talk a little bit about Sweden. They evaluated the efficacy and safety of vitamin K antagonists, which was predominantly Coumadin or warfarin, and aspirin in AFib patients, and they did a risk-based assessment using a CHADS and a CHADS-VASc, and a bleeding risk assessment with a HAS-split, and they looked at the net clinical benefit, which was, again, reduction of stroke or thromboembolism subtracted from 1.5 times the intracranial hemorrhage. They weighted the intracranial hemorrhage a little higher than they did the other events because of the perceived disability. So they actually made that stronger. Aspirin alone was not associated with any positive net clinical benefit for any risk strata. The only group that had a net negative benefit from Coumadin was the patients who had a CHADS-VASc of 0. The combination of aspirin and Coumadin didn't yield any additional benefit. The bleeding risk between the two was pretty similar. So this is going to be a summary slide looking at warfarin versus control, aspirin predominantly versus control, and adjusted dose warfarin versus antiplatelet agents. If you look at the risk reduction from aspirin, it's about 22%. Again, it's very modest. If you look at warfarin versus control, risk reduction is 64%. If you look at warfarin versus aspirin, you have a 39% risk reduction. So in summary, aspirin has a very modest preventive role compared to placebo. Aspirin alone is not a good option, and compared to aspirin, warfarin offers a much more effective stroke prevention. The risk of intracranial hemorrhage with aspirin is no different than that with warfarin. So the Swedish atrial fibrillation cohort trial. Anyone familiar with who Gregory Lipp is? That's one. What else? Has-split score. That's correct. So he's an outcomes researcher in Birmingham, UK. He works at the Birmingham National Institute of Health for Clinical Excellence. He's done a lot of outcomes work in this field. He's responsible for the Danish cohort trial. He's responsible for the Swedish AFib trial. You can see this was published in Circulation. So they looked at about 2% of the Swedish population. Sweden has a population of about 9 million. And they looked at the Swedish Hospital Discharge Register. Again, it's a pretty accurate database. It misses a principal diagnosis in about 0.5% of patients. And they looked at the combined endpoint of death, ischemic stroke, or intracranial bleed. And again, they looked at that net clinical benefit. They got data from about 260,000 patient years, 1.8 million hospital contacts, 18 million prescriptions. An HDR diagnosis is accurate pretty much 97% of the time. You did the positive predictive value with Richard. A diagnosis of stroke or TI is correct 99% of the time. A proportion of stroke events accurately identified during the hospitalization based on good validation studies is about up to 98%. So it's a pretty reliable cohort study. Outcomes feed Not all cohort studies are great studies. Comparing treatment effects is best with a randomized controlled trial. But every cohort study is as good as the data that you look at. The follow-up was 1.5 years. They had enough events, so they were powered to draw good conclusions. And if you remember no other slide from today's talk, I hope you remember this one slide. Hasbled score, CHA2DS2-VASc score. So in patients with a Hasbled score of 0 to 2 and a CHA2DS2-VASc of 0 to 2, no oral anticoagulation underperformed oral anticoagulation. Not surprising. Low bleeding risk, high stroke risk, oral anticoagulation outperforms no oral anticoagulation. No surprise. This is surprising. A few years ago, people who were getting taken for lariat procedures or being randomized to Watchman were patients, quote unquote, who could not take anticoagulation because of their perceived high bleeding risk. In the Swedish AFib trial, patients with high Hasbled score and low CHA2DS2-VASc score, oral anticoagulation still outperformed no oral anticoagulation. Reinforces the Danish cohort trial that at no risk strata is no anticoagulation superior to oral anticoagulation. What Matt said, what bleeding risk does, you look at your Hasbled calculation, hypertension, abnormal liver, kidney function, S for prior stroke, B for bleeding, L for label INRs, E for elderly, D for drug. Elderly, hypertension, previous stroke are the same factors that are driving your CHA2DS2-VASc score or your CHA2DS2 score. Why this is important is once you have a patient who's had a bleed, the natural tendency is to stop anticoagulation and go back on aspirin. Aspirin effect is modest. There is no bleeding risk. That justifies the patient not being on oral anticoagulation. That's a generalized statement. There are individual cases where you need to modify that. But the science suggests that oral anticoagulation is superior to no anticoagulation, even in patients with high Hasbled scores. From the Swedish AFib cohort, they identified the patients who would have no net clinical benefit from oral anticoagulation. And if you believe that cohort is sort of similar to Minnesota, Swedes, and Norwegians, only about 4% of all your patients with atrial fibrillation are going to derive no net clinical benefit. So the vast majority, 96% of patients with atrial fibrillation, would be patients who would benefit from oral anticoagulation. What's the bleeding risk with Coumadin? In the Swedish AFib cohort trial was 2.7. If you look at this was zimalagatrin, idraparinol, this was warfarin, it's somewhere up about 2%. So the reason for not using warfarin, Gregory Lipp and others have written about it, is really not patient preference. It's physician overestimation of perceived risk of bleeding. It's a subjective call. It's not a real call. It's not based on any of the evidence. So, anticoagulation, not antithrombotic therapy, is the optimal strategy for most patients with atrial fibrillation. If you can't orally anticoagulate a patient, aspirin has only very modest benefit. And aspirin and clopidogrel is really a questionable strategy, but you know, which is worse, a stroke or a bleed? And really that's what you're asking the patient to choose between. That's really a patient-centered clinical decision making. So how do we select patients for anticoagulation? You all know this. CHA2DS2 was validated from the stroke prevention atrial fibrillation trials, JAMA article in 2001. CHA2DS2-VASc was developed and validated by Gregory Lipp from the EuroHeart survey. It's a 1,000 patient cohort, pretty small. There are other bleeding risk calculators. Anyone familiar with any of the others? This is anticoagulation risk, right? This is outpatient bleeding risk, endorsed by the American College of Physicians, apparently, American Stroke Association, ACC, AHA.
What is your system with bleeding?
It's anticoagulation. Yeah, risk assessment. So, why is a CHADS VASC better than a CHADS score?
It's lower. You probably capture those that were low, not that were before no risk into, you re-stratify patients into a slightly higher category that was otherwise not captured. So you're increasing the pool of higher risk patients that were not captured.
So in the CHADS, which was a simple scheme that everybody liked, with a CHADS of 0, these patients still had a 1.9% stroke event rate. So the CHADS VASC reclassifies those patients who are perceived to be 0 CHADS or extremely low risk. CHADS VASC at 0 has a 0. It's not exactly 0, just rounded up, but a 0 stroke event rate. At higher risk, CHADS is more accurate than CHADS VASC, but who cares? If your risk for stroke is 15 or 18%, same difference. This is some hazard ratios from the Swedish AFib cohort trial. I'm not a biostatistician or an outcomes researcher, but you can see age is the primary driver of risk, hazard ratio of 5. CHADS VASC assigns a 2 to age. Female gender has been added to CHADS VASC. Previous stroke gets a 2. This is vascular disease. I think many of the guidelines categorize vascular disease as carotid aorta. Previous bypass, you can actually expand this. Known coronary disease, peripheral arterial disease. Heart failure gets a 1. History of heart failure gets a hazard ratio of 0.9. So there doesn't seem to be that strong correlation.
Heart failure. So the initial CHAD score, like age 01, they say heart failure within the last 100 days is what that was derived by. Whereas I think the CHAD-2 VASC was any history of heart failure.
So the European Heart Journal and the European Society of Cardiology guidelines specify this. So the C in CHADS VASC is pretty much what you're saying, Ryan. It should be moderate to severe LV systolic dysfunction, heart failure with reduced ejection fraction, or episode of decompensated heart failure requiring hospitalization, be it heart failure with reduced EF or heart failure with preserved ejection fraction. So, CHADS VASC has bled. At no time does your has bled or your bleeding risk exceed your need for anticoagulation. This is a clinical decision-making tool. It's a patient counseling tool. You'll counsel the patient on their bleeding risk. If the patient knows they could get a GI bleed or a nosebleed or some other kind of bleed, they will more willingly take their anticoagulation therapy. So until recently, we only had warfarin therapy. Now we have the newer agents. They're not so new anymore. I should probably credit Dr. Garcia. You should probably stop using the term NOAC. Apparently, there's been instances where people have interpreted that to mean no anticoagulation. So, target-specific oral anticoagulants or whatever you want to call it, they're not new anymore. Call them by their name. So there have been 4 pivotal trials on the newer agents, all published in the New England Journal of Medicine, McMaster Group, Duke, and I think this was Brigham and Women's. And we'll go through all of them, and we'll go pretty fast. So, direct thrombin inhibitors, you all know this, TRAN, dabigatran, dimelligatran, work through factor 2. Direct activated A inhibitors, rivaroxaban, apixaban, edoxaban, work through factor 10A. All the studies were pretty similar. Combined, there's about 72,000 patients. the dabigatran, Rely was a open label, the others were double blind. They had different doses based on renal function. And I want you to keep your eyes on rivaroxaban for a reason. I remember someone saying they liked the Xarelto once a day dosing. Patients on the Rocket trial, Xarelto had a higher CHADS score. They used CHADS, then CHADS-VAS wasn't in vogue. The others were pretty similar. Half-life. Dabigatran is dosed BID. Rivaroxaban is dosed once a day. This doesn't compute for me. It's one of the criticisms of rivaroxaban. I don't know how we got to there. Apixaban, twice a day dosing. Different doses based on renal function. So the trials again were pretty similar. They looked at efficacy and again safety. They had two primary endpoints. Efficacy endpoint and a safety endpoint. Bleeding, most people now define using the same criteria, which is the International Society for Thrombosis and Hemostasis. Hemoglobin drop of 2, transfusion of 2 units, or bleed into a critical site. So in the Rely trial, you all know this probably by now, dabigatran outperformed warfarin at both doses. It had an intention to treat analysis, and then modified intention to treat analysis, which was an as-treated analysis. In the modified analysis, it showed non-inferiority. There was a signal for myocardial infarction for dabigatran. It was a numerical signal, numerical increase, but not statistically significant. But it'll come up later. So rates for hemorrhagic stroke and intracranial hemorrhage were lower for both doses of dabigatran. GI bleeding was increased with a higher dose, but there was a non-significant but numerical increase in MI. The FDA approved a separate dose for dabigatran. Does anyone know why? What was that? But the Rely trial had a 110 milligram dose. So there were pharmacokinetic and pharmacodynamic studies that weren't published in the manuscript. And the when they do the drug application, the FDA got a hold of those. And based on that, they came up with this separate dose, no clinical trial. I came up with a separate dose of 75 milligrams. And we'll get to that. So a meta-analysis of the dabigatran study showed significant increase in MI. That's one study. The other studies have shown no increase in MI. And the FDA, and I'll show you in a later slide, have done a registry and showed no increase in MI. So rivaroxaban, I want to spend some time on rivaroxaban. 14,000 patients, CHADS score a little higher. This is one of the problems with rivaroxaban. Sorry, I should have had a pointer. I have a white background. The time in therapeutic range. Anyone know how to calculate the time in therapeutic range or what that implies? So the goal is to have your patient between 2 and 3. So less than 2, you're out of therapeutic range. More than 3, you're still out of the therapeutic range because then your patient has bleeding risk or bleeding event. It's a pretty sophisticated formula that's used across the board for clinical trials. It's called the Rosendahl method. They have a fudge factor. They look at the last time your INR was normal, look at the shift, the delta, and the days in between, and calculate a correction factor for the period since your last INR and for the delta change, whether it be up or down. And that's how they come with the mean time in therapeutic range. So the study population was higher, but the mean time in therapeutic range was 55, median was 58. Time in therapeutic range is very important because one of the legitimate criticisms against the Rocket trial or rivaroxaban is that the warfarin arm was terribly undertreated. This has become a recurring theme. There's data out, and I think this was from Sportif, which was a zymelogatran trial, that if your time in therapeutic range is above 75, these patients actually have significantly lower events than patients whose time in therapeutic range is less than 60%. So, rivaroxaban claims is an untreated arm that it was non-inferior to warfarin. If you look at safety in the as-treated population, there were no difference. These are Kaplan-Meier curves that show that in the as-treated population, rivaroxaban versus warfarin is kind of blown up. They're pretty much overlapping. But this is an important take-home message that Rocket trial showed. At the end of the trial, after the rivaroxaban was discontinued, patients who had been on rivaroxaban have a rebound. They seem to have increase in thrombotic events. If you interrupt rivaroxaban before a procedure, there's a concern that this might be a signal for thrombotic events. Subsequent NOAC trials, particularly the ENGAGE-AF trial, the edoxaban trial, took this into account, and patients would be bridged from the time the study drug was discontinued to time they were put back on their usual therapy. The second criticism against rivaroxaban, that discontinuation can lead to a rebound in thrombotic events. The third criticism from rivaroxaban is significant GI bleeding. Patients who go on rivaroxaban get quite a bit of gastrointestinal bleeding. So rivaroxaban was non-inferior to warfarin for the primary endpoint of stroke and systemic embolism. In the intention to treat analysis, it was not superior, it was comparable, it was not inferior, but there was no reduction in mortality, no difference in major bleeding, but also rivaroxaban had much higher discontinuation rates than warfarin did. And it's a pretty significant number. So apixaban, Eliquis, time in therapeutic range was slightly higher. Similar patient population to dabigatran with a CHAD score of 2.1. Apixaban was non-inferior to warfarin, and they had a pre-specified endpoint of superiority, and apixaban was superior to warfarin therapy. In the primary outcome of stroke or systemic embolism, apixaban outperformed warfarin. With regard to stroke, all categories, not all categories of stroke, but hemorrhagic stroke, apixaban outperformed warfarin. With regard to death from any cause, apixaban met statistical significance and outperformed warfarin. So in the Aristotle trial, apixaban seems to do as well or outperform warfarin in pretty much all categories, and it was as well tolerated as warfarin was. In subsequent cohort trials, Gregory Lipp again has looked at patients on the newer agents and has shown that for apixaban and dabigatran, even in patients with a CHAD score of 1, these patients derive a net positive benefit from being on a newer oral anticoagulant. Edoxaban. Have you guys done these in Journal Club here? All these trials?
So even if you go back, sorry to interrupt, but even in Lipp's analysis, rivaroxaban, again, his real-world signals are indicating the intolerance of rivaroxaban. So it's making up for the chance of that higher bleeding risk.
And that's correct. And rivaroxaban has other problems. We're not going to do too much about the occlusion devices. Part of Boston Scientific's application to the FDA for approval of Watchman was that the stroke event rate in the warfarin arm was 0.7.8%. So their warfarin arm, they claim, was far better treated than in many of the NOAC trials. In the rivaroxaban arm, the stroke event rate was about 2.4%. With the other NOACs, it was about 1.5, 1.6%. So whereas Watchman did not meet statistical significance for their primary endpoint of non-inferiority, they claim it's because their warfarin arm was so well treated. The device has been approved. But rivaroxaban and the signals are pretty consistent. Okay, so we'll finish. You get the trend. NOACs, less, same, non-inferior, maybe superior with regard to a safety profile. except for gastrointestinal bleeding. And it was the same thing with edoxaban. Edoxaban was in between dabigatran and apixaban with CHADS of 2.1. CHADS score of 2.1. This was 2.8. They had slightly higher risk patients. Their time in therapeutic range was the highest of all the studies, and they had different doses. A higher dose and a lower dose for patients with a GFR of between 30 and 50. Low-dose edoxaban underperformed warfarin. So I'm not sure that too many people are going to use low-dose edoxaban. High-dose edoxaban did just as well, or was non-inferior to warfarin, and in some instances was superior, especially with regard to reduction of ischemic stroke. With regard to major bleeding, low-dose edoxaban had less bleeding events than warfarin. But with regard to our primary endpoint of stroke, it outperformed, so I'm not sure where low-dose edoxaban is going to end up. I go back to the intention to treat analysis versus modified intention to treat. As treated, high-dose edoxaban meets statistical significance versus warfarin. If you use intention to treat population, they're no different. Does anybody know why this is the case? This wasn't written up in the manuscript, but subsequently come to light, and you can see it in these numbers.
Probably you can't always address the reason for it.
So in an intention to treat, when you do your analysis, you analyze everybody, right, including your dropouts. In your as-treated or modified intention to treat, you don't. You put only the ones who stayed on therapy. So look at their ends for the patients who are on their modified intention to treat, 182, 196. They had a 33% discontinuation rate of the study drug. It's a problem. I don't know. 1 out of 3 of all your patients on edoxaban in the trial discontinued the study drug. I don't know what the significance of that means, but it's also been FDA approved. It's Savasa. Is that how you pronounce it? It's the last of the most recent one to be approved. I think it was in January of this year. Okay. So with regard to major bleeding, fatal bleeding, bleeding in the critical organ, if you tolerate edoxaban, you seem to do better than if you're on warfarin. Again, like with rivaroxaban, dabigatran, you have higher GI bleeding with these newer agents, except apixaban. Apixaban was superior across the board. So this is a slide I got from, which kind of summarizes everything we've just gone through from one of the VA docs. The VA has a pharmacy benefits manager. And so it's a pivotal trial, CHAD score, time in therapeutic range. Again, we point out that rivaroxaban patients in the warfarin arm were really undertreated. Reduction in stroke or systemic embolism, apixaban was superior. Dabigatran is not superior at both doses, was superior at the 150 milligram dose, was not comparable at dose, the 110 dose. Nobody knows what the 75 dose is going to do. With regard to mortality, there was less all-cause death with the apixaban, and with the others in registry, there seems to be a favorable trend. So let's go over some controversies here, and I'll be summarizing here real quick. So is dabigatran cost effective? The way to test for cost effectiveness, anybody know the standards that policymakers look at to test for cost effectiveness of a therapy?
Usually you look at the incremental cost over the current gold standard. So the comparison is whatever is the current gold standard.
Sure.
You'll get an incremental benefit and then standardize the life, or I don't know, I guess.
So I'll try and oversimplify it because the way I understand it, and you're onto it. If you have a patient who's in perfect health condition, you give a quality of life of 1. If he lives for a year on a treatment, you get a quality adjusted life year of 1. So for example, you have a patient now with hip pain, who needs a joint replacement, if their quality of life is at 0.5, they're living out a year, and you give them a hip, and you improve their quality of life to 0.75, you've added a 0.25 benefit to their quality of life. Over 4 years, that 0.25 benefit is calculated as a 1-year quality adjusted life year. Does that make sense? Over 10 years, it will be 2.5. Then you look at the cost of treatment of this new therapy, $100,000, divide by the quality adjusted life year. So let's go back to the hip example. If your hip quality adjustment is 0.25, and you live for 10 years, you'll get a 2.5 quality adjusted life year increment. If the cost, initial cost of the hip was, I'm going to exaggerate, $100,000 to get easy math, the incremental cost effectiveness ratio will be 100,000 divided by the 2.5. Okay? 40,000. Now it's up to society to decide, are they willing to pay for this treatment? So then comes the willingness to pay threshold. With dabigatran, the quality of life year increment was no different than warfarin. But now it depends on your pharmacy benefits manager and how well they negotiate. Some health systems have quoted a quality adjusted life year incremental cost effectiveness ratio of 45K. Some have quoted about 12,000. This would be like a VA system or a Medicare system. Yeah, go ahead, Jen.
Do they include the cost of testing in that?
Cost of?
Cost of INR testing?
I'm not an outcomes guy, but I presume they usually do. They take all costs and come up with a figure that's generally accepted. But so in this country, what's considered to be the upper threshold for quality for incremental cost effectiveness ratio is about 50K. That's why you hear all this controversy about aliroikimab and Sovaldi for Hep C. So with regards to major GI bleeding, this is FDA safety communication. They have a registry. There's been a signal with dabigatran of major GI bleeding. What time was your next speaker? Keep going here. Keep going. Okay. So with regard to all NOACs and MI, and pooled data of all the trials showed that there was no difference. So there's really no signal for MI with the newer agents. Something came up in the media. In 2011, there was a post-market reports of severe bleeding and deaths amongst patients with taking dabigatran. There was, of all deaths, most of them were due to warfarin or dabigatran. And this sort of triggers FDA to go back and look at the data. There were court cases, there were depositions, there were lawsuits, there were subpoenas. The company behind dabigatran eventually paid $650 million to settle all charges. New York Times wrote a pretty nice article. Why?
They don't like cardiologists.
That's one. So in the interest of time, there are large differences. This is only with the thrombin inhibitors between individual A and individual B. There's a 5-fold variability between different individuals when you use a standard dose. This was known to the FDA during the approval process. There's a cardiologist, Darren McGuire from UT Southwestern, who sat on the panel. And he wrote about his concerns, and they were put into the record by the FDA. But nothing was done about them until the lawsuits. So as part of the subpoena process, internal company documents were revealed. And it showed if plasma levels were measured, and the dabigatran dose is reduced by 30 to 40%, is reduced, you can decrease events against warfarin. These are safety events by 30 to 40%. So it's a significant reduction in safety events. The dose adjustment, when you look at plasma levels, has very little effect on its effectiveness on reduction of stroke. But then this undermines their whole policy, their whole message. This may not be a one-time test and will result in a more complex message, regular monitoring. So there is a signal for dabigatran that it is not a fixed regimen therapy. There is a role for monitoring. If you're an optimist, I would say this data is actually pretty compelling. If you monitor patients on dabigatran and adjust their dose, you might have a better effect. You may have a therapeutic window. And indeed, the company's own data shows this, and they published this in 2014. This is not actual data. These are logistic regression models where they come up with an observed versus expected event rate and plotted dose, bleeding events, reduction in ischemic events, and trough levels. Trough levels were collected 10 to 16 hours after dose administration. Peak dosing was 3 hours. And they showed that at a dose between 50 and 200, you get rid of most of your ischemic events without increasing your major bleeding events. So the European monitoring agencies, European Medications Agency, actually has put a labeling with regard to that. They recommend that 40 to 50 nanograms gives you stroke prevention. Less than 200 milligrams prevents excess bleeding risk. So pretty much like warfarin, there might be a role for monitoring with dabigatran. It's not an every day, it's not an every week monitoring. I don't think anybody knows.
Has there been any internal documents about the variability in levels? Because there's really been not a significant number of, the warfarin and interactions and things along those lines. That hasn't been published out.
I think internal company documents showed significant variability in levels. The company actually had done a pharmacokinetic sub-study of 2,000 patients within their big 14,000 patients, where levels were collected regularly. And of the entire patient population, 70% had levels collected. So they had a lot of data. And this was known to them. There were internal communications, email communications, saying that you're going to undermine our value proposition, that dabigatran is a fixed dose regimen therapy. What boggles the mind is knowing this, that you can adjust the dose and reduce bleeding events, seems to result in actually a better drug. The European Medications Agency has figured that out. And so there are assays to do monitoring of direct thrombin inhibitors. None of these is FDA approved in this country. I think Hemosil is a research tool. In Europe, these are available. This is eccrine clotting time, and they monitor dabigatran levels. And so I think the reason I put this out there, I think with some adjustments, monitoring of dabigatran might be a useful way to work with patients and have them on the therapy that actually works and reduce the bleeding events. What if a patient bleeds? How do you treat patients who are taking NOACs? There's historically not been much known. This is a figure from the European Society of Cardiology. You do your monitoring. If it's minor, you discontinue dose. If it's moderate to severe, these are all supported measures, charcoal. If it's very severe, for dabigatran previously was recombinant factor 7A or a plasma prothrombin complex concentrate. There's a 3-factor, there's a 4-factor. Very expensive. It's made from fresh frozen plasma. But those of you who attended the AHA know about idarucimab. I think it's just been recently FDA approved as Praxibine in the last month or so. So it's going to come online. This is a Pixaban antidote. I don't think it's been FDA approved. So we're going to have antidotes available. So we're going to summarize here. The American guidelines say if you have a CHA2DS2-VASc of 1, oral anticoagulation gives a class 1A. What do they give the new oral anticoagulants? 1B. Why? I think so. I don't know. That's speculation.
One trial.
But there's 4 pivotal trials. Randomized, New England Journal of Medicine, all of them. I think the policymakers realize in this country, first of all, the cost of our drugs are much higher than in Europe, where we have national health services. They've felt that maybe as policymakers, they need to maybe not go down that road. Some of the people in the guidelines writing from India are very thoughtful people. The Europeans have actually gone out on a limb. These are European Society guidelines. They say NOACs offer better efficacy, safety, and convenience when oral anticoagulation is recommended, and NOAC should be considered instead of coumadin. They give it a class 1A. They've downgraded coumadin. We haven't done that in this country. I think a time and place will come when we do that. Obviously, we've got to do with incremental cost-effectiveness ratio. So I'll finish soon, and this is really 2 slides on left atrial appendage closure devices. There is a Watchman device that's been approved. This has a CE mark in Europe, where getting approval is pretty easy. And you're all familiar with the Lariat device, which is, there's an FDA safety alert. Historically, there have been surgical exclusions. This is my problem with closure devices. I think there's a place for them. About 16% of all strokes are thought to be related to atrial fibrillation. Of those, we think only about 10% are originating from the left atrial thrombus. So you have 10% are related to AFib that we quite don't know. And you guys are familiar with that big German population study that looked at patients who had just increased CHADS score, or the CHADS VAS score without atrial fibrillation, and that stroke event rate. You presented that, right?
I didn't, but
Khalil did, yeah. So not all strokes in AFib are coming from the left atrium. So if you're occluding the left atrium, are you really preventing stroke? The other reason is not all left atrial appendages are the same. Some have a single lobe, good for the Watchman device. Some have multiple lobes. How does it work? I'm not sure. And only time will tell. But if you look at the PREVAIL trial, which is a PREVAIL AF trial, that looked at Watchman devices in their second trial, that led to the approval. They didn't meet the non-inferiority endpoint, but their pitch, Boston Scientific's pitch to the FDA was that their warfarin arm was very well treated, and this got them their approval. The advisory committee voted 13, I think, 2-1. So I'll stop there. Yep.
Very fascinating. The question is, like, you know, so that, like, seems like a system seems to be, like, superior or almost better in every way compared to, like, the rock band and the biggest. So why is it the VA? So that's the big kind of one issue for the level.
So there's a couple of things. One, I'm not sure it's superior compared to dabigatran, or you need to do a head-to-head trial. I don't think anyone's going to sponsor that trial. That's the only way you can tell for sure. But in their patient population, it looks like the outcomes were very good. Actually, the VA has actually accepted you can get a Pixaban for all vets now. You can. They just don't advertise or announce it because then people, there'll be a rush to get a Pixaban. Having said that, I personally have a problem with rivaroxaban. Part of the reason I think sometimes going through some of this data, even though some of it is a lot, is mind-numbing, is there are very smart folks I know who will start patients on rivaroxaban because it's a once-a-day therapy. The warfarin arm was undertreated. You saw that slide that shows time in therapeutic range, where you have greater than 75% on warfarin. Your patient with that time in therapeutic range is actually far better off than your patient on rivaroxaban. So if you put resources into coumadin or anticoagulation clinics and get your time in therapeutic range up there, I think you might do well. It should be part of the medical record. I don't think anyone's going to invest in it. Yeah, go ahead.
Some people have looked at real-world analysis of time and therapeutic for warfarin, and it's even lower than what we've seen in clinical trials.
That's
certain paper on it.
That's correct, but there's the Danes claim 70%.
Oh.
4.5 million people. You can do a lot of stuff. You can have significant adjustments. They've been using ICD-10 since 2000. Anyone know when ICD-10 was finalized by WHO? 1992. We're starting to use it now. Why ICD-10? Because if you're a policymaker and you want to make population-based decisions, the data in ICD-10 lends itself to asking big questions. As you see, Gregory Lipp has done this in Denmark and in Sweden. With cohort trials, you can ask big questions, test treatment effects in real-world populations, and make significant population-based interventions. That's why the U.S. authorities are actually bringing it Oh, yeah, well, Australia was the first country, so it's been a while. Canada was in 2000. So, yeah. So that's a very good question, Chadi, and I don't have an answer to that. This the problem with the new therapies, a lot of unintended consequences. One is bridging, two is discontinuation, and I have slides about that, and I didn't go into that, otherwise we'd be here for 2 hours. The onset of action of these new therapies is pretty rapid. It's within 4 to 8 hours. So if you stop it for procedure, pacemaker, cath, when do you restart it? If you stop it for surgery, when do you restart it? Everyone's trying to get out there with a paper saying, for Pixaban, I'll hold it for 24 hours. For something else, I'll hold for 36 hours. It's all made up. I think you need decent trials. So I don't think anyone has an answer with regard to bridging. If you read the Doxaban paper, the Engage AF trial, they actually have in there a protocol that they use at termination of the study for their patients. And I think it must have worked because we don't see any post-discontinuation curves that show a rebound in thrombosis. So I don't know. I don't know anyone has an answer to that. David?
Like that, on all those final and also, as a core of three, has almost, let's say, isolated or incident, have the same risk of limited and stroke to a person chance alcohol. One is continuous. If within the reach of the level ratio on or a time, what we can use for a even, but you don't have a fit for patients with high chance alcohol.
I think you make a good point, and that's why that paper that Khalil presented, the German population study, very flawed because their cohort, their database was all over the map. And they had used patients from the eye clinic and all over the place. But I think there are people who are looking at this. I think the Germans are trying to randomize folks to anticoagulation just based purely on having a high CHAD score, CHAD-VAS, who don't have atrial fibrillation. But in that trial, they also are going to have an arm where they do intense monitoring to make sure they're not missing episodes of paroxysmal AFib. I don't know what intense monitoring is. Implanted loop recorder, I don't know. But yeah, it's a good point. Dr. Chandra believes what you just said, that you have pathology within the whole circulatory system that's predisposing, and that might be the target for these anticoagulants. Okay, well, we'll stop there. Thanks for your time.
Yeah, right, no kidding. Thanks, that was awesome.
Thanks for having me. Where's Peter and George?
He's on nights.
Okay. Well, thank you for the invitation.
Oh, no, great.
There's a lot of material.
Oh, but you know, honestly,
And be mind numbing.
no, it was perfect. You know, did everything. And how long has it taken? Well, it's obviously a topic that you studied for a long time, but just putting that together was a no small endeavor.
Unfortunately, yeah. But if you start on the subject, you may as well finish it, right?
Well, that's what I liked. I've done I had an artifacts and new imaging, you know, and it was a big 45-minute talk, but it forced me to pull out textbooks. It forced me to do a whole lot of things that I thought were, you know, I probably wouldn't have dug into as well. And once you know you're going to get that topic, it helps really push you to look up some things and dig further.
Yeah, and that's why I think, you know, imaging is so much easier because you throw a bunch of things that work through a case, like the fiber monitoring. You know, just an example. Here's annulus. How are we going to measure it? Then walk people through the standards. This tends to be it, because especially with an informed audience, it will be easier to mention.
Yeah, right. Exactly. That's always it.
Telling the cognoscenti, this is how you calculate CHAD's value.
Yeah.
They'd run me out.
What is it again? I got this. Thanks a lot, man.
Yeah, oh, no problem. Thank you. Oh, no, thank you.
Change my perspective when we're
Oh, you're taking over the podium, right?
part of it, and this is not to diminish this guy, part of it. And because that was supposed to be the expert. Yeah. I can, when I do your image talk advisor, I'll show you the case that I did, that was related by, I don't know, a patient had been driving a loss van, and they held it for a flatter ablation. Then the day before they brought it, they did it, and you had a mass in his RV. That's an ablation? No, before. But he had that, it's like when you drive a loss van. Okay. So township said you wouldn't do the flatter ablation before the patient was shown from a street.
Oh, even though on the rock band.
It had been, but that did like for 3 days.
Oh, 3 days. Oh, okay.
So, they did the TV and it looks like there's a prominent moderator band in the RV. So we played a national USC. The mass in the RV, the moderator band was gone.
Moderator band's gone.
No, the mass is in the right ventricle. So it's no longer in the right ventricle. So where did it went? So the same CT shows the mass. Massive. So the mass, they took driver oxygen and on TV the day before.
Yeah, mass.
In the RV. But no one could decide what this was. They said the moderator band and tried to draw the modulation. And but then they say because we didn't quite sure what that mass was, what can we do? Let's do an MRI. The Chandler said, no, he doesn't want to do an MRI to have mass. Looks to evaluate that RV mass.
Yeah.
Right with the CT, we couldn't see the mass in the RV. So I call him and I say, I don't see the mass here. But while scrolling through the lung images, this massive massive.
So, you want to do a refill?
So my point is this driver was
I usually thought when I was going to that, obviously, one of the things that in the trials is that they were had a higher CAT VAS score. Not only did they were they like less therapeutic.
I agree completely, but that's how the salespeople boggle because our patient population had a higher, but because it had a higher population, we could have expected more events and so more power to show evidence, but they didn't. That's true.
No, this is okay for patients.
What's the subject? Okay, so exit state. Okay, well, I'll see you when you come back. All right, okay, take care. Oh, thank you.
Yeah, maybe, hopefully, maybe use this meeting.
Show us some fancy.
Hopefully not you can. How does your thinking go there? Okay.
Yeah.
Oh, nice. Yeah, I'm finding my food classes,
Right.
FaceTime?
Yeah.
What time is it in Jersey right now?
Probably 4 a.m.
Yeah.
4 a.m.
I was gonna say
Yeah.
it's probably 2 a.m.
That's a little early. It's probably thinking.
Yeah, college Bristol.
Actually, Dr. Sangucci.
Oh, you can prepare.
Yeah, big calibers.
Yeah. There's definitely a lot of stuff to go over, but we'll see if we can get through it.
Yeah, you got a lot.
Sorry, yeah.
Well, I think also some of it is a lot of already involved and stuff. That's a lot of technical stuff. Like,
So you got one hour?
I guess more than that, because it's a short match on it right now. Oh, you're presenting, Shai's presenting, Ryan's presenting? Wow. Maybe over a little bit.
You can go on a little bit. I'll go under, I'll sacrifice some of my time for you.
I do have some other stuff to go over too, like if you had more time. We will see.
Wonder what the case will be about. If I go for my interview.
Yeah.
You got the caliper.
Yeah.
It's a good time.
Yeah.
Yeah.
I think that's the one thing, like, for our youth presentations, that's like the smallest percentage of the people
Oh.
who really present.
I know, I was thinking that, I was looking for a game too, that because we do less of that, so.
I learned so much.
And we're coming up to it, I'm like, beginning of January, all set,
Yeah.
so.
Hopefully it'll be, any travel plans soon, or?
guys, I have a list of delinquency here to read off. Sorry, I'm the bad chief, Steven's the fun-loving chief, so, it is what it is. So, Marina, Markowitz, Lake, Kazmierek, Stephen George, like I said, fun-loving. Jake Jessen, Kate Picel, Jessica Voigt, and Katie Carlson, with Ostrick and Papianos recently crossed off, meaning they have just completed.
That was like a week.
You have not, yeah, Young Quad is still on the list. But send your update, even if it's nothing, you know, how fun that is to write. You know, the first years, this is just to get in the habit when Elizabeth emails you for updates, send her something. She will hunt you down and make your life miserable. So just say, here's about posters. I finished up something, just give it like a brief update, because Ganesh uses this to track our progress throughout fellowship. And so if there's nothing, just say nothing. Or, you know, but she needs to have this documented as part of our fellowship, ACGME, blah, blah, all that stuff, okay? So please send her that email. I think she sent it out a couple of weeks ago. So I got the list. Not a couple of shame, but I did. Anyway, sorry. With that, Bill.
All right, so, good evening, everyone. Thank you for all coming back. First of all, I want to thank Dr. Sakaguchi for being my faculty mentor. This case actually kind of started off with Dr. Tolakana Ali, but he's actually out of town. So Dr. Sakaguchi also is aware of this case, so he will be our faculty mentor for this evening. So thank you for coming. All right, so, you know, for all my presentations, I kind of try to make it interactive. And so this time, since we've kind of changed our VA call schedule, so you're on VA call this weekend, and it's a Saturday, and you already got called in to see a patient that was acutely ill, and then you get this page from the ER. Okay, so the ER calls you for a rapid heart rate and low blood pressure.
Sure.
All right, there you go.
Have Drexel or me, who's are usually working there.
Not why are you calling me?
Matt's probably seeing like 5 patients right now, like in the ER, so he's busy. So let me tell you a little bit more about this patient. So he's a 59-year-old Vietnam veteran, and he's had a history of palpitations in the past. He also has PTSD, dyslipidemia, and unfortunately during the war, in Vietnam War, he actually lost his right eye, so he has a right artificial eye. Okay, just interesting. Okay. So he came to see Matt, or you guys, for acute onset palpitations that morning. He was a little short of breath and just more fatigued. Okay. What he tells you is that about a few months ago, he said that he had similar symptoms, and he felt that his heart was fluttering, and it would last for a little while, it'd go away, and then after that, he just feels really, really tired. His medications currently, he's on Dilt, simvastatin, and aspirin. In terms of social history, believe it or not, he never smoked. He drinks occasionally, no drugs. He's married, and he's retired at this point at age 59, and he has 3 grown children. So here is vital. Okay, so a little bit on the lower side in terms of blood pressure. Heart rate nice at 150, and he's having okay. When you look at him, he looks a little bit in mild distress. AVP really doesn't look elevated to you. He's definitely tachycardic, as you can tell from the exam. He's regular, but no more resources gallop. Lungs actually are clear. Stomach warm, really no lower stomach edema. Labs, I just tell you that they weren't really remarkable. Chest X-ray, normal. Okay, and we did get an echo, with otherwise 60-65%, which even in his heart rate we were able to get a ECPF. Okay, so you know, as you can imagine, Dr. Sakaguchi here, like ESP and EKG. So here's the EKG that the ER physician gives to you because of the console. You fill in this rate. Want to interpret it? Call. All right. So we'll start. Sergey, you want to give it a shot?
So rate tachycardia at about 150. Normal axis, I don't see the changes that I can appreciate. I don't see T waves.
Mm-hmm.
So yeah, so some sort of SNC going at 150. It's possible that it was detached for long PR, or maybe, like ADNRT.
Mm-hmm. Good, good, good.
Two, no, long PR, none of them.
Yep, so, I mean, this is real time, so you're here. What do you think? Someone that's a little, like, pull that in?
Yeah.
We have calipers.
If that's the T waves, I would suggest to me that maybe he has some respiratory P's from.
Mm-hmm.
Sort of.
I would want to see an old, I mean, you know, it's so hard to, you know, it's so subtle and I don't.
All right, so, I mean, this is like a real consult, you know, he gives you the EKG, you're in the ER, Matt's really busy seeing patients right now, so he says, well, what do you want to do? 90 over 50. He's talking to you though. Yeah, he's going at 150, he's not desaturating.
They maneuvers were done.
Okay, well, you can try vagal maneuvers, okay?
Yeah.
Okay, so let's say we gave orodenosine, so we gave those two and both of those actually work.
Well, of course.
Yeah.
The modified vagal.
So
Did you go back into psychology where you lift the, you have to lift
What's
the
that?
leg? Did you go back into?
No, you didn't go back into
Why
it.
did you do both?
I said either or. So you can do vagal maneuver or adenosine.
Both work in general.
Both would work, yeah.
I thought you said that both work.
No. No.
No.
No.
See how it ended? Yeah, that's.
What's that?
Do you see how the tachycardia ended?
We don't have
Good
that.
question. Can you, because I thought a lot about this. Can you discuss a little bit about, you know, the termination of a narrow complex tachycardia if at multiple different reentrant arrhythmias cause, you know, how they terminate? What's the most helpful thing in a termination for FCT, I guess, is a better question. Sorry.
Well, because you're gonna go to the differential.
Yeah.
Okay.
Okay, so differential techniques. So, I mean, like,
Go back for just a second.
yeah.
Just so, you get a little bit and then,
Yeah.
I guess that's why you were asking.
Yeah, though, in 2, 3, you know, there was that, and if you go back one more, keep going. You said, yeah, I think two is pretty,
Key things right here.
yeah, and 2.
Right, that little, it's what it's just on.
Oh,
It's
sure.
not there.
Not there.
Yeah, right.
So, you know, based on the EKG, you know, even Sergey kind of alluded to it, you know, there was some possible concern for AV and RT, so that's one. What else are you guys thinking about?
Can I ask a question? You got consulted in 2009. Go back one. Keep going. August 2009. After he was cardioverted. I just find him.
So it's been a while.
Yeah.
Since he had his last episode of application. All right, AVRT, anything else that you guys thinking about? Okay. We're really like the main, but, you know, also you can see 2-to-1 flutter. But, you know, just basically looking at it, it doesn't look super suspicious for flutter, but it is also should be on differential too. Otherwise, I didn't figure it out.
It has to be a long PR, right? This is the short RP.
Yeah. Yep. Possible if you didn't believe that the P waves were truly, yep, it could be accelerated junctional.
Can you give an accelerated junctional to the rate of 150? That's not too cheap. Can you get an accelerated junctional tachycardia to the rate of 150? That's been.
Yeah. In fact, that becomes one of the more difficult things to try to distinguish is conjunctional tachycardia from AVR.
All right, so now, you know, some of you may have gave adenosine, and some of you may have done a vagal maneuver. Either case, the patient broke. And now he says, "Doc, I feel better." He tells the ER doc, so he wants to go home. What do you want to do? So he's on DILT 360. So,
Yeah.
so the possible options are obviously you discharge the patient, maybe.
What was he on that DILT 360?
Mm-hmm.
So,
That's a lot, so,
make it DILT 488.
yeah. All right. So, I mean, this is all prior management, you know, you're coming and seeing the patient for the first time, so.
When's the last time this happened?
Mhm.
Or did it ever
A
happen?
few months ago. A few months ago.
2 months ago?
Yeah. Seems like you had it for a long time, because in 2009 you had EKG, so it's
Did
been
he take
ongoing.
the drugs? I mean, if you rule out the fact that he's been compliant, isn't drinking alcohol, isn't, you know, and it's happened every couple of months, then you don't really have an impetus if the
No.
guy comes in and is relatively stable. I mean, as long as he gets seen on a relatively shortened time frame,
Mm-hmm.
it's fine, just send him home.
All right, yep, so outpatient EP consult, EP, is that?
Is there any method to check on thyroid? Because I tend to do that.
Yep, thyroid was normal. Yeah, and he was taking his medication. Okay. All right, so obviously, discharging patient seems to be like what we all agree on. Would you admit the patient for observation? Probably not. Outpatient EP consult, EP study? No, so follow up with general cardiology.
Well, he's symptomatic. Yeah, there's multiple times, like,
Yeah. Okay.
I think you at least, sending him to do it, if he's symptomatic, he's already been on medicine,
Yep.
he's had a pretty good shot at it. I think the discussion should, at least the diagnosis.
Yep. So, you know, like Matt was saying, when you see the EKG, he goes, he's a fast SVT, short RP, he's symptomatic. So you're thinking like some type of AVNRT or maybe AVRT. And so it's not unreasonable, to, you know, follow the EP and consider EP study.
But I tend to get especially for the EP, I tend to have the holder, ahead of time, so the EP has the holder.
But do you need the
So
whole?
you know, because we have an EKG showing, we actually captured it.
The burden, you might want to know what the burden.
Symptomatic, he's symptomatic.
Yeah.
It is helpful. It depends on how often you get it. I mean, he's had 2 in his life, chances that he's something else. But it's only taking one, so, you know, the ER didn't give you the termination. You may take a determination, maybe initiation.
Mm-hmm.
And if I could just sort of take a moment here, ask some question. He showed a differential diagnosis, which is basically the differential diagnosis for all SVT. AV node reentry, bypass tract, and an atrial tachycardia. We just sort of actually have a bigger group that we call primary atrial tachycardia. Difference, basically, in an atrial tachycardia, source of the arrhythmia is the atrium. It could be an ectopic focus. It could be flow, reentry. To answer Matt's question, what happens, what do you look for when you look at a termination? In an atrial tachycardia, the driving, everything, the source is the atrium. So when the tachycardia terminates, the last cardiac beat will, unless you have AV block, be conducted to the AV node, and you will terminate with ventricular ascent. Whereas a bypass tract, typically you go down the AV node, up a bypass tract. When you terminate, what happens? You give adenosine, you block the AV node. The last thing that happens is the atrial fire. So you'll terminate in the atrial. It will be very unusual for an atrial tachycardia to terminate with an atrial event unless the patient happens to get AV block at the same moment. AV node reentry, you usually go down the slow pathway, not the fast pathway, which is the weak link. It's usually antegrade slow pathway. So the last event is usually the
Thank you, Dr. Taguchi. All right.
So it's just a low likelihood of an APAC if the last event's an A, like, there's usually an AV node dependency. It's just unlikely that you're gonna have the AV node launch at the same time that the atrial path already terminates, which is the reasoning.
Right. So just the caveat that we got an ATAC, water with 2-to-1 conduction, and can't. Actually, you can tell a little bit here, and the AV node reentry, if you have a reasonably good AV node reentry, now with low pathway, you go up the fast pathway and down, about the same time. So the VA time is going to be very, very short, even if, okay, unless you've got a thick AV node, and then in which case the RMT time will lengthen. Whereas with AVRT, it takes time to get from the ventricle up to the respiratory pathway, so it's simply a little bit longer. If it's really short, AV node reentry. If it's longer, it could be this with well. But a very short VA time. Very strong argument for it.
That's significant for RTE or for this
VA time.
VA time.
VA time, yep, and it's very characteristic for AV and RT.
It comes from a very seminal paper from Japanese, I believe,
Yep, and actually, I tried to find that paper. But yeah, the history of AV and RT diagnosis actually came here, so it's actually really cool. So, I think, in terms of EP, so I won't belabor it too much because there's more to my case presentation. But obviously, you generally want to do EP studies when you're concerned you want to kind of better understand the cause and diagnose management for like flow, bradyarrhythmias, obviously tachyarrhythmias, which we'll talk about a little bit. Patients who have unknown syncope, unknown etiology, and you want to kind of assess, the SA node, AV node, or evidence of ventricular tachycardia is also another indication to get a EP study. And, for patients who, may have, sudden cardiac death was undocumented and it doesn't have any coronary disease, you can see if you can induce it. If you can induce it, then actually prior prevention, if patient has not had sudden cardiac death and you're concerned for arrhythmia, you can see if you can induce an EP study, the indications for that. So, does that make sense? All right. So, EP is, for me anyway, I don't know if it was for you, it's a very cerebral field of cardiology, but very interesting. And it's one of the few fields I think that we can actually do some curative management. And we can ablate WPW or like AVNRT. And so it's one of the things that, unless you actually understand the language, you don't really get to appreciate the remarkable things that we can do in EP. And so I want to take an opportunity before we actually look at, intracardiac tracing to really understand what we're actually doing in EP labs, because I think that is an important foundation to know. Like anything, I think it's important to understand the anatomy. And so basically, a lot of these images are actually from Fogarose. If you ever heard of that book, it's a very good book. And so this is basically the anatomy of the conduction system, obviously the SA node, AV node, tip bundle, one branch, and Purkinje fibers. The one unique thing to remember is that at the, along the AV canal, there's a fiber skeleton in the heart, and that fiber skeleton cannot conduct. The only way you can get conduction across the AV is if you have a accessory pathway, which is basically some extra muscle, okay? Key thing to remember is the AV node. AV node is actually a very special part of the heart, and it has a special conduction property called decremental conduction, okay? So what is that? So basically with the AV node is that the more activity or signals you send down the AV node, the slower the conduction is. Okay, so that's something that you have to remember, and that's something that we use a lot in the EP lab, and that's a basic concept you have to remember, okay? So the faster the rate, the slower the conduction through the AV node, and that's an important concept, which is not characteristic of, say, accessory pathway, okay? Another thing to remember is, if you guys remember this action potential that you see all the time, but really don't really think a lot about. Well, this is kind of a core understanding of anything in EP is this action potential. because this action potential kind of tells you the electrophysiologic properties of the heart, okay? And this is just the particular action potential for the ventricular muscle. And as you know, that basically all the medications that we use for antiarrhythmics affect action potential. And if you have ischemia and you injure the muscle, you have scar, and this action potential will change, okay? And those changes will affect certain characteristics we'll talk about in a little bit, like conduction velocity, refractory period, automaticity, okay? And so basically, you know, I don't need to kind of go through the different phases, but, you know, phase 0 is depolarization, sodium channels open. Phase 1, potassium channels start to open and go out. Phase 2, plateau phase, that's when the slow calcium channels come in to kind of prolong the repolarization phase. Phase 3 is when you have the outward potassium channels, okay? And basically, these are the kind of the electrophysiological properties that are kind of essential that we tend to look at is the conduction velocity, refractory period, automaticity, okay? Any questions? Make sense? Okay. All right. And again, I kind of already said this, but, you know, like the pathology is usually related to the changes in the action potential, okay? And so this is just to kind of show that, you know, different types of muscle have different types of action potential, okay? And, you know, for automaticity, the difference is that in phase 4 for the ventricular muscle, phase 4 is a flat line, whereas for automaticity, in phase 4, you have slow inward potassium channels called the plenty channels that continually go up such that, you know, once you meet a certain transmitter potential, it activates, okay? Another important concept to remember is refractory period. This is also very important, okay? And there's 2 types of refractory period. And the refractory period we always hear about is the effective refractory period, which is from here to here. It's basically, during that time, you can do whatever you want, nothing's going to happen, okay? Because, you know, the muscle needs time to recover. However, when you reach towards, you know, the latter third of the phase 3, you can have the relative refractory period, and this probably occurs after the effective refractory period, and during that time, you can get depolarization. The one thing that's unique about it is obviously the slope for the phase 0 is a little bit is less steep, and so that's the one thing to kind of remember. Okay. As you can imagine, as I mentioned before about this action potential, is that certain medications affect the action potential and therefore can either instigate arrhythmias or can actually decrease arrhythmias. So don't think that antiarrhythmic drugs stop arrhythmias. They can also start arrhythmias too, and it does that by changing the action potential shape, okay? So as you can see here, I just want to go through quickly here, you have decreased conductivity because the slope of the phase 0 is less steep, and you increase your refractory period, as you can see, right? Procainamide does that, okay? This one, the refractory period decreases. Lidocaine does that, okay? Class 1C, you can see here, you have decreased conductivity, which you can see the slope. Flecainide, which we can commonly use for AFib, does that, okay? Class 3, which is the drug we use all the time, increases action potential duration and increases refractory period. And the Orgaron does that, okay? Lastly, which we sometimes use a lot in AFib, is the decreased conductivity. This is AV node, and diltiazem is a medication that affects the conduction through the AV node, okay? So as you can see, the stuff that we do actually affects the action potentials and therefore affects conduction, refractory period, and automaticity. So those are I want to kind of bring home those terms, so we'll be using those a lot, okay? Any questions? All right, another thing to remember is, you know, our heart is innervated with a ton of nerves, so obviously, as you can imagine, you know, autonomic tone can affect conduction, refractory period, and automaticity, right? So sympathetic tone obviously will increase conduction velocity, decrease your refractory period, and increase automaticity. Makes sense, right? And then increased parasympathetic tone will decrease conduction velocity, increase refractory period, and decrease automaticity, which again makes sense, right? The one thing to remember is that the AV node, compared to all parts of the heart, is actually richly supplied with parasympathetic fibers. So therefore, when you use the vagal maneuver on the patient, you know, it will work because you increase the vagal tone, all right? All right, so now let's get, huh?
It does have fairly big.
Yeah, we have sympathetic too, but when you look at, you know, the comparison of fibers, there's more tension. I was told that, I like the red.
Okay, well, don't ignore the fact that that's sympathetic.
Yep. Hence it increases the conduction velocity through the AV node. So it does have sympathetic. Thank you, Dr. Tegerty. All right, so now we're kind of getting into the nitty-gritty of the EP study. So what are we actually doing in the EP lab, okay? So the EP study at its core does two main things, okay? One is that it records the electrical system of the heart. Obviously, you have all these catheters in, and they have all these electrodes, you know, cathode and anodes, and what they do is it records the heart's electrical system. And the second thing we do is we pace the heart at different areas and see what happens, right? And so the catheters that we use, obviously, we have a catheter in the high right atrium. We have a catheter located in the hip bundle, catheter in the coronary sinus, which I want to allude to, is that it allows, when you do the coronary sinus, what things are we actually assessing is that we're looking at the left atrium and the left ventricle. As you can imagine, it goes to the coronary sinus. The things to remember when you look at these intracardiac tracing is that you'll see CS 910 and CS 12. So remember that CS 12 is actually the distal part, is the tip of the catheter, and CS 910 is actually, you know, like the more proximal part of the catheter. And that is the proximal part of the closest to the AV node. This is farthest from the AV node. You guys with me? Okay. And then obviously you have the RV lead, which can also sense and pace. Okay. So essentially, as you can see, just like an EKG, we do EKG on the chest. This is kind of like a nice EKG intracardiac, because if you know your basic cardiac anatomy, which I kind of went over, and you know all the positions of the catheters, you can actually map almost everything in the heart, except the right side. Does that make sense? So this is why the EP study is actually really interesting, okay? And so this is kind of a nice pictorial exam of all the different types of catheters, okay? So obviously, what's this one? High right atrium. How about this one going down here, going into the coronary sinus? Yeah. Okay, how about this one here going down here? RV. And then this guy, this, and this is your ablation catheter.
So where would CS1
So CS1 would be here, and then CS910 would be here. Does that make sense? So proximal, distal, okay? And this is important because this is going to help, if you understand these concepts, it's going to help you map what's happening in terms of electrical conduction in the heart, okay? And lo and behold, this catheter is actually pointing towards the flow catheter. All right, and then this is kind of like a nice tutorial here. This is the EKG. This is the regular EKG that we normally see. This is the high right atrium, so this tells you the signal. And the one thing to remember about the EP study is that we're only looking at depolarization. All these catheters are filtering out repolarization, only looking at depolarization. So all this is depolarization aspect of the what's happening in the heart. So high right atrium, this is the hip, atrial, his signal, ventricle. This is the proximal CS, and this is distal CS. Okay, so we can see that you see that the conduction is going down from proximal to distal. It's very subtle, but that's the conduction. And then lastly, you see the RV. Make sense? All right. So now what hits is some terminology, nothing too difficult. All things you've heard before. Okay. Cycle length. I don't need to say anymore. But the thing to remember is that the shorter the cycle length, the faster the heart rate, right? Coupling interval. So this is the interesting thing. So coupling interval is that sometimes you can pace. So you're pacing at, say, 300 milliseconds, right? The coupling interval is the interval when you pace a little earlier. So if you pace at 300 milliseconds and you bring in another pace beat, say at 150 milliseconds, the 150 milliseconds, that's the coupling interval. When you bring in a premature impulse, the time frame when you bring it in, that's the coupling interval. I'll show you a picture in a little bit. Okay? Incremental pacing. This is something that we also do, which is basically you're pacing at a specific cycle length. So like 600, 8 beats at a time. Okay? And then program stimulation. So this is what we do to help, either terminate or activate different types of tachyarrhythmia. Is that either you can pace at specific coupling intervals, or you can provide a train of pacing. So you do incremental pacing, and then you bring in another premature impulse, okay? And we do that in the EP lab to see if we can induce arrhythmia, all right? So this is kind of a nice picture. So as you can see here, for each cycle length be 400 milliseconds, which is about 150, right? This is the RV apex. This shows incremental pacing. In this case, it's at 400 milliseconds, so it's all the same, okay? And it stops. Here, this is program stimulation. This is kind of an example of it, where you incrementally pace, this gets at 600, and then you bring in a premature impulse at 250 milliseconds. And so in this case, the drivetrain is at 600, and the coupling interval is what? 250. Does that make sense? And so basically what you see in the EP lab is you keep a specific drivetrain, and you keep bringing in your coupling interval, and you see what happens. Because remember with the AV node, right? If I bring in the coupling interval, what's going to happen with my conduction? It's going to slow down because of decremental conduction, okay? Okay, and so essentially, this is basically the different intervals. The one thing to kind of remember, which we'll talk about a little bit, is, the PR interval is made up of the A, H, and V. And what we'll find is that the AH interval will actually vary, as you can imagine, as we change our coupling interval. Did I lose anybody, or we're all on the same page? Okay, good. All right. If anything, hopefully you guys will come off with some basic knowledge, okay? Another key concept, we're almost there, concentric activation. So concentric activation basically goes through normal conduction. So when you see normal conduction, that's concentric activation. Eccentric activation, when you pace, and the conduction goes through something that you do not expect, which is, say, an accessory pathway, okay? And that's called eccentric activation, okay? So a quick example. So I just want to kind of emphasize just the key points. With concentric activation, obviously when you activate, in this case, we're pacing in the RV, okay? When you're pacing the RV, remember, this is kind of different from what you normally think. You go from RV to AV node to A. Does that make sense? So if you pace in the RV, this is the V, and this is the A, okay? So what you would expect is you're pacing, say, in the RV apex, the CS proximal will get activated first, right? So that's the most proximal. As you can imagine, too, the atria closest to the AV node will also get activated, and it's going down this way. So this is normal. And that's concentric activation, okay? I don't want to belabor it because we won't see it most of the time. Check this out. So when you pace, this pacing is much faster. Remember, we're going at 500. You bring in the RV pacing, coupling interval, or the incremental pacing time is shorter. Remember, we're going from V to AV, right, to A. So as you bring it in, the VA interval gets longer compared to the last one. Remember, the V and the A were very close. See? Here, the VA is longer, and guess what's interesting? The distal catheter gets activated first instead of the proximal catheter. Okay? So so that's eccentric activation. So when you see that, you're going to have to be thinking, this doesn't look right, there must be something going on. Okay?
It was.
Yep.
Not the exact same crit.
Okay?
Almost the exact same crit.
But do you see? Okay? So, yeah, and it was actually a centric pathway, okay, in the entraining thing. Okay, so basic EP protocol. Okay, this is what we generally do, but each attending will do it differently. Okay, some cases will do like RV pacing first, some people like to do atro pacing first, but it doesn't matter. They all do the same thing. The first is called atro pacing. Basically, look at the SA node automaticity and conduction, which is basically overdrive pace. The SA node, and you see what happens. You stop, and you see what happens. AV node conduction, you kind of saw that earlier, and you look at the His-Purkinje conduction. And then ventricular pacing like the last eccentric activation, you see what happens. You see if there's any retrograde conduction, okay? And then you can induce ventricular arrhythmias by programmed stimulation, okay? And you can do drug testing, you do isopril and all that jazz, okay? And then you see what happens, okay? All right, now we're getting kind of more of the good stuff. I won't belabor too much because Dr. Sutherland already mentioned it. But when we talk about SVT, the three kind of big players are AV and RT, which kind of makes up 60% of all the SVTs. AVRT is 30%. Atrial reentry is the remaining, so it'll be like 10%. Okay, and obviously the AVRT is an AV node. This is a macroentrant, which requires a accessory pathway, whereas this is only in the HVAC. Got it? All right. So the thing is, there's a common theme about reentry. The common theme is that you have to have a dual AV node or dual pathway, meaning that you have two types of tissues that have different electrophysiological properties. Okay. Otherwise, reentry doesn't really make sense. So just looking at A, so obviously, I think you guys already know this, but there's a slow pathway, and a slow pathway has a short refractory period, okay? And then you have a fast pathway with a long refractory period. So this is, you kind of have to believe me on this one. Believe on faith that this is the case, okay? And so basically, arrhythmias can happen when, when you actually provide a premature impulse that comes in when one of the pathways is refractory and it goes down the other pathway. And okay, you guys follow me? So we have premature impulse and it comes in here and the fast pathway is refractory, so nothing goes down. Remember, the fast pathway has a long refractory period, right? The slow pathway, then because it can't go down the fast pathway, it goes down the slow pathway, okay? And it goes down super, super slow. And the fast pathway eventually will recover. So by the time it recovers, the slow pathway will go down the ventricle, but also can go up because it's now it's already recovered. And when it goes up, it can cause an SVT. Okay, this is a common thing to remember this, okay? And you can see here, look at the difference. Look at the PR interval, right? Short, long. So you can imagine the PA interval, because of the premature impulse, comes in early, and it goes down the slow pathway. Okay, common theme, just remember that, okay? You got that? Okay, AV-NRT, same deal, right? So you got the AV node, you got the accessory pathway, both are different tissues, right? This one has detrimental conduction, this one does not. So in order for this to happen, this rhythm to happen, you have to have a premature impulse that comes in at the right time where this is refractory. So nothing goes down the accessory pathway, but it can go down the AV node, okay? But because nothing has happened here, it's refractory, when it goes down, it can go back up, okay? And it creates a macro reentry circuit, okay? One question I get, people ask, or these medical students ask me, why don't you always have AV-NRT? Well, the thing is that this guy also gets activated most of the time. You may, either you see it, which is non-concealed, accessory pathway, but in some cases it can be concealed, okay, and you may not see it. All right, make sense? So it's kind of the key concept we already talked about. You have to have two pathways with two different electrophysiologic properties, and they have different conduction velocities and refractory periods. And this is AV-NRT, we talked about that. And then the AV-RT, you have AV node accessory pathway. Okay? And the EP study can help you differentiate between these different types of arrhythmias. All right. All right, now to the good stuff. Okay, so we all on the same page, you guys understand? So when you're going to be in EP lab with Dr. Sakaguchi and you see all these tracing, it's like, I got this. All right, so basically, I'm just going to go through the first one, okay, just to kind of let you guys do it, but I think for time's sake, I may have to go through all of them. But, okay, so obviously this is the screen that you'll normally see in the EP lab. This is your EKG, high right atrial catheter, your HIT, you have your CS, and your RV. In this case, we're not doing anything. We're just kind of, all the catheters are in the heart, and we're essentially seeing what's happening, right? So So basically, if you look at here, atria, right, gets activated, you sense an atria, okay? Atria, so in the hip, the prox hip gets activated first with AA, and then obviously in the coronary sinus, the prox gets activated first, and you see that little nice little slope down here, okay? And then you get on AV node, this is the hip, and this is the V, okay? I just kind of do that. Here's prox, it's distal, and that's normal, right? You saw that earlier. AH, because it's going down into the AV node, and you have V, okay? As you can see, I don't want to belabor too much, but the V tends to happen a little bit earlier in the distal, and that's actually normal, okay? Because obviously you have the Purkinje fibers that kind of go around, so the distal part of the LV also gets activated at the same time. So this is the same picture. Nothing has changed. I'm just showing you the AH interval, okay? AHV, and then this is the AH interval, and then the HV interval, okay?
Secretary, the V for the HD is the earliest sharp deflection that you go for the.
It's the, you measure the HV interval by the earliest critical deflection any place.
Any place, okay.
So the AH interval is trying to estimate AV node convection. And this catheter is sitting right over this atrial activation is the atrium right before you enter the AV node. Now you're in the AV node, and as you exit the AV node, you grab your hips. The hips bundle conducts very fast. So it's a pretty, whereas the AV node conducts very slowly. So it's a pretty good estimate of AV node conduction. HV interval, you're trying to estimate entry into the history of the H. Exit. No. Anyone. So as a surrogate for knowing where an exit, we take the earliest depolarization anywhere. That's also why we have it that way.
We may be able to see that today, we may not. Okay, so,
We'll get there.
all right. Okay, so this is program stimulation, drivetrain 600, coupling interval 420. All right, so what I want to show you here is that, so you see this, you see the A to H interval here, it's not that long. But then when you bring in the coupling, when you bring in the early premature beat, look at the AH interval. They're lengthened. They use your little thing like a sensation, and you don't believe me. So you see the AH interval here? Okay, this is a drivetrain of 600, right? When we bring in the 420, look at the AH interval. Longer, right? And that's normal, because that's the AV node. You see decremental conduction. All right. So now, so as you can see, like what happens in the EP lab is that you do these program stimulation. You start at like 600, or 600, 580, 570. I'm just showing you the highlights. Okay.
By the way, Matt, you know this is
All right.
Thank you, guys, Aguchi. I wasn't outdating. Okay, so AH interval, I wanted to show you that it's different. It's longer, right? Because you're bringing it in, and that's what you expect because of decremental conduction in AV node. All right. So AH time gets longer, improved coupling interval, decremental concussion. Okay, this is repetition is the mother of all learning. I've heard this 5 times. Okay. All right. So guess what happens? I go from 600 to 410. Look at the interval. It went from 198 to 365. But when I went down from 420 to 410, there's a big increase in the AH interval, which is like, remember, like the going down. What path are we going down now? Low pathway, right? So essentially, we brought in a premature impulse that was refractory down the fast pathway. It goes down the slow pathway, and you actually see the prolongation of the AH interval. Okay, so now we're like slowly going down the slow pathway. The fast pathway is refractory. Okay, and this is called the AH jump. So have you ever heard this term? This is what's happening. Okay, so you jump, right? from the fast to slow. The definition, from Dr. Bendit is that if you have an interval increase of greater than, I should have had this definition. But if you have an AH interval that is greater than 50 milliseconds, when you decrease the coupling interval by 10 to 20, that's the definition of AH jump. Okay? So in AH result went from 198 to 265. AV and RT starts. Okay, so I'm just going to go over it for you, and I'll show you how cool it is, okay? All right, AHV. Remember, now we're going to go up the fast pathway, right? So see the fast pathway is going up, and you see the A. Does that make sense? Remember that picture I showed you? The little circular thing? So it's going down, and then it goes up the fast pathway. And remember, the VA time is super short. Does that make sense? And then it goes on the V. Okay, and then it goes on slow pathway. Okay, and then H, V, up the fast pathway, down the slow pathway. Okay, do you see that? Yes or no? Okay, so basically we just activated in the EP lab AVNRT, just by doing program stimulation.
Is there anything else that can cause essentially simultaneous activation of other than AVNRT?
Yeah.
Okay. Okay, the fast junctional attack.
Yeah.
What are some of the clues that can differentiate that? Is there anything in terms of observing it in this situation?
In this situation, no. If it's
Okay.
Maneuver is a totally different topic. I have some maneuvers to show you, but, you know, I think our time is limited, so, if I have another opportunity, okay? And then fast pathway, okay? And then this is just the picture I want to show you what happened, okay? So this is what happened. So you use my diagnosis in the EP study, that patient has AVRT. Obviously, you'll do some maneuvers to make sure it's not like a junctional tachycardia and so on and so forth, but that's not the topic for today, okay? So the EKG strip, so remember what Matt mentioned, or I think Surya mentioned, there was like a, you know, like a retrograde C wave. The EKG, especially in the V2, you get the pseudo S prime, and then you get the pseudo R primes in V1, and that just shows you, like, you know, you wouldn't see it in a normal EKG. All right, and then the tachycardia cycle length, which is how fast it's going, fast pathway, slow pathway, fast pathway. Okay, so basically, just remember, so this is the V, and it goes up to the A, down the AV node. Okay, obviously it's also going down the A and the V here, but I just wanted to show you just in the hip and the HRI to kind of demonstrate the key concept.
And you're still concentric in your CSV.
Yep, and it's still concentric, as Jeremy mentioned, it's going down from the prox to the distal. Okay? Okay. So this is, so basically, you know, I just want you to see just some anatomy. This is a triangle of Koch. And basically, these are all the same 4 pictures. The only thing different is that you see catheters and more diagrams to demonstrate what's happening. So basically, through the coronary sinus, this is the slow pathway, this is the fast pathway, and the triangle of Koch is this triangle here. Okay? So this picture is basically the fluoroscopic picture with all the catheters in, you know, the ablation catheter, which is on the slow pathway, and then you have the hip and the coronary sinus. Okay? And this picture is the same picture, similar to this, but with catheters, and this is with everything. Okay? And so essentially, this is how you ablate the AV-NRT, because you put a catheter in the slow pathway because you made that diagnosis, and then you ablate it. This is just a cardinal picture, nice picture of CT showing where the slow pathway is, where this little guy here. These are just cool pictures, but we can use Cardo to help identify the location of the slow pathway, and we can ablate it. Basically, Cardo is when you take a CT of the heart and you use 3D mapping, and that 3D mapping is correlated with the catheter. So you can actually
You don't have to do CT.
You have to?
Basically, there are various systems in which the computer can locate the catheter, and you can take that catheter and treat the entire geometry of the chamber, stores it. And then you take that catheter and put it in a different location, and it tells when that particular site activates. Picture the atrium, and by color coding, where the first part of the firing. And you can use it to locate and, you know, put it on a hit on it.
So you get to be very specific in terms of what you're doing, so you don't make any mistakes. You don't want to burn the fast way.
Cardo has a triangular EKG. For those of you rotating through the EP lab as a general fellow, I think some of the best time, the most you can learn about stuff is helping them get set up for the patients, because they go through setting up all the Cardo, at least we're using Cardo, which is plasma cluster, but they set all these things up, they put all the things in the computer. You can kind of get an understanding for what they're doing from just the basic mechanistic point. Otherwise, you start throwing colors and picking up on the screen, and you're not going to understand what they're looking at. But if you go through and do the whole setup, you actually learn a lot from the text and what's going on.
All right, so we graded it, he's feeling better, get followed up, he hasn't had any palpitations for the last 6 months. Okay, so we actually cured his palpitations in the EP lab. All right, so 456, I have another case, but I don't know, do you guys want to go through it, or?
Show the electrogram.
Electrogram?
Show the electrogram.
I have someone nodding their head, so.
What's that?
You want to do it?
Yeah. Just show the electrogram.
All right.
I'll just skip everything. Electrogram.
So this is EKG, for this patient, given adenosine and growth, okay? But, we won't see anything interesting. So, kind of similar, maybe a P wave.
RP looks longer though.
Maybe a P wave right there.
The problem here is, you know, which twiddle is the P wave?
Right, yeah.
Okay, so could there be, could there not be? Okay. And this is the EKG after. Adenosine. All right.
I have to go back to,
All right. Yeah.
is there just any creative type thing?
Real is low. No, I don't know. I doubt it. CR's not short.
All right, so we don't know, maybe.
Not obvious.
Okay, all right, so maybe another AV and RT, okay, so, all right, so now this is baseline intracardiac, okay? A, H, B, okay, so you guys see the pattern here? Okay, all right, and so now we're pasting in the A to do the AV and RT, now we're pasting in the RV. So R pacing, and then this little thing here, that's the signal for the V. This is the signal for the A, and it's going from the prox to the distal, okay? At 500 milliseconds, so this is what we're pacing at. Okay. All right, so now I'm pacing out 460 incremental pacing. Do you see anything different? Eccentric, right? So V, you see, we're pacing earlier, the V to A is a little bit longer, right? H and A. You see, it's not from prox to distal anymore, right? It's actually starting somewhere around 5, 6. Okay? Eccentric activation, atrial activation occurs in the occurs in the CS before the hip. You see that the hip A occurs after the CS. Does that make sense? So that's kind of odd, right? That means it didn't really go through the AV node. All right? And then the A is last, okay? Which is not what happened before. Okay? Because this happens after the hip. See a difference? Before. Okay? All right, so B, H, A. So eccentric activation. Okay? And so now we'll try to see if we can activate the tachycardia. So now we do activate at 350, so B, and it goes up the accessory pathway, which is the eccentric activation, right? You guys see that? B, okay, and then H, and then H. And then accessory pathway, post-accessory pathway, it goes up to the A, okay? It goes down the AV node, to the V, right? It goes through the pathway, up to the A, down to the AV node, okay? And the same. You guys see that pattern? Yes or no? Okay, so basically, just basically looking at this, which is, if you didn't know anything, it would be just a bunch of wiggly lines. You can actually see that the activation of the tachycardia, which in this case is AVRT. Okay? Yeah.
So, accessory pathway. Remember, we did not see a delta wave. So there were a couple of possibilities. Some accessory pathways will conduct antegrade only. Pathways will activate retrograde only. Some will activate in both directions. We'll only see delta waves. They activate from top to bottom. Okay? So this is probably what we call a concealed bypass. They can have a bypass track even though you don't see it on. It's also possible that the patient has delta wave that conducts top to bottom, but you don't see just because the AV node works fairly well and bypass is just so far away that it's normal condition.
And again, this is program stimulation, and the program stimulation was able to.
Bill, I would draw your angle down to the V first. See how you have it going? Sure. I just think, because how you have it drawn is a little. This is coming earlier, right? So the angle is actually down here. Okay, you can draw, because this happens first. So then it comes back up.
Oh, I see.
Comes down, because when you draw like that, it makes it look like it's going to the CS, but in actuality,
Go down here.
to the V first. So AV,
Yep.
AHV, because you're seeing the hip here. So AHV, CS back up to the A. That's what's happening in terms of,
Go down here. Down to
right.
the-
but we don't get this in the EP lab. We gotta look here. So
Yeah.
A, H, V, back up to the A. You guys all see that? Because when you draw, it's right, but it's a little confusing because your looks like the V is next early. So the HV interval is shortest, and then you go back up.
Okay. All right. So once you diagnose that patient has AVRT, we do some other maneuvers to kind of make sure we will go over. But it looks like the earliest activation is around here, right? You guys agree? Okay. So in order to ablate, you have an ablation catheter, and you basically align it so it lines up to where you think which CS node electrode you're at, and probably about here, you see it lines up, okay? Then you ablate. So as you ablate, it stops, and then you have the normal activation, okay? So this, and the patient is actually in tachycardia at the time that you're ablating, right? So again, B goes up the accessory pathway, goes all the way up to the A, and then goes down the AV node, to what Matt mentioned before, goes up the down to the V, and then before it can actually go up the accessory pathway, it's ablated. And so tachycardia starts, and then you have the regular activation.
So this is very cool. The last thing you see is a V. Remember, you're burning that accessory pathway. Essentially burning the pathway, it can't get to the A and it ends.
Cool? All right. So 2 cases, EP has cured 2 patients today.
Quick break, and then we'll present our cases.
Great job.
You learned a lot.
Good job, Bill. You were the first general counsel who's not going to get an EP to tackle a cardiac.
Oh, yeah.
Are you still,
Oh, yeah, no.
No, that's okay. It takes 2 seconds. We're good. See you. Right here. We're good.
So here you're pacing the ventricle. You're on your early phase, in the corner. And now you're tapping you're pacing the ventricle, you're going through the sensory calibration. Look at the VA interval here compared to the VA interval here. This is very
So let me think about that. And, is it because the hit is, well, the Kenji system is closer to the accessory attachment and the catheter?
yes. And on top of that, I think it probably means you got a slant. So look at this here. You're going from right ventricle, then you're activating the left ventricle from mid left. Whereas here in tachycardia, you're activating the Kenji system, so you're activating the left ventricle sort of the same time as the right ventricle. But you still have to explain why the time from A to this B is so much shorter than this one. Was trying to go like here.
Oh, yeah. Yeah.
So, it's going off. When you're in tachycardia,
You want to do EP, right?
What? Well, I want to do
Are you set? Okay. How long will your presentation last? 10 minutes? Or it's just free? Yeah, quite nice. Very good. So they give me the allocated time of 8 or 10 minutes. Yeah. So what are the questions that you think you can They've been asking why there's a higher What is the atrium, the third scoring system? They almost the same, but they add
The APIC lab is up and running.
You love it, don't you?
Well, it's a lot of fun. Yeah, and, the system that we built is eliminated the process. Oh, yeah.
So, you're choosing this and, that's off, what you start with?
They're just rolling, starting, yeah.
I think we'll go ahead and get started in a few minutes. I think Chad just stepped down. This is a tradition that, why don't we shut the door right here? So this is a tradition at most academic medical centers. They always present their posters and their oral presentations before the AHA and or the it's been going on for many years. I remember the first time I did it, it was a different faculty, sitting in the front row. And where I was, Dr. John Ross was the chief of cardiology, and he was a very formidable figure. And I remember getting up and I had to present an abstract on how to diagnose WCW by echo. We had a lot of criticism. The main thing he said to me, I'll never forget it, I learned a lot. He said, do you really believe these data? You don't show very much animation. You know, when you present about 50% of it is science and 50% of it is actually excitement, and indicating to the audience that indeed this is really important to you. That do it again, or I had to do the whole thing over again, and it went much better, and it was a good lesson. So I think that's one of the reasons why we do this. It's also to kind of anticipate the questions that might come up. The very first time I presented was in New York City. It was an echo paper again. The audience was packed. And the first question was from someone from Japan, and I could barely understand the question at all. I had no idea what he actually said. It was embarrassing. And the moderator was very kind. A guy named Dr. Harvey Feigenbaum, some of you might know his name. We had the person repeat the question. So anyway, it's a time-honored process. It's an important process. My advice is to go slow, enunciate your words, make sure that we can clearly hear your message, be excited about your message, be on time. It's supposed to be 10 minutes or more. And then we'll open it up for some questions. So we just have 3. I think it's better to concentrate actually on a few than to try to get to 20. I don't know how many abstracts are actually being presented, but I know it's quite a few. All right, so our first speaker this afternoon is Chaddy. Everybody knows Chad. And he's going to be talking on the Chad 2-VAS score and the risk of ischemic stroke and atrial fibrillation. And his mentor is Untitled. Chaddy, why don't you take it away?
Thank you so much for inviting me to the talk. And as Dr. Francis, this is a good practice for me, so I will save all the questions till the end. If you have any questions, please save it, and we'll have enough time at the end. So the title of our work is the CHA2DS2-VAS score and the risk of ischemic stroke by atrial fibrillation using the atherosclerosis risk of community study, the ERIC study. And this is the list of the author, and the mentorship is Dr. Lynchen. To give you a little bit background of the study, the CHA2DS2-VAS has been widely used clinically as a score risk to risk specify the risk of stroke in patients with AFib. There's some studies showed that some signals suggesting, especially in patients with MI and heart failure, that the CHA2DS2-VAS score can be used to stratify the risk of stroke in patients with no AFib. And anticoagulation, furthermore, may be indicated in patients with high CHA2DS2-VAS score, even in the absence of atrial fibrillation. And this is, the author came to conclude that probably the vascular risk factors and not the AFib itself that drives the risk of stroke in this cohort. Going through the literature, this is the three major studies that done regarding that. The first one was published in 2014, where they looked into the risk of stroke and CHA2DS2-VASc strata. And as you see here, there is an increase in risk of stroke in each increase in the CHA2DS2-VASc score. And this was statistically significant. And this is especially in patients after acute coronary syndrome. Another group did study and published in March 2015, and they used they concluded that the CHA2DS2-VASc also could conclude or could correlate with the risk of stroke in patients with no atrial fibrillation after open heart surgery, either valve or CABG. And lastly, this is published just 2 months ago by Gregory Lip. Everybody heard his name today multiple times, in JAMA. And in this study, they looked into the CHA2DS2-VASc and risk of stroke in patients with no history of AFib, but with history of heart failure. So as you see here in this diagram, there is an increased absolute risk of stroke in patients with and without AFib. However, it's unknown at this point whether CHA2DS2-VASc score correlates with the risk of stroke in community dweller, and especially the one who doesn't have history of AFib. So that will take us to the aim of our study. We have two aims. Number one is to investigate whether the CHA2DS2-VASc score could predict ischemic strokes in community dwellers without history of AFib. And the second aim is CHA2DS2-VASc score could be used to guide anticoagulation therapy to prevent stroke in community dwellers without, again, history of AFib. We hypothesized two things. Number one, the CHA2DS2-VASc is associated with ischemic stroke in community dwellers without history of AFib, again, and the CHA2DS2-VASc can be used to guide anticoagulation therapy in a general population without AFib. In order to study these two questions, or two hypotheses, we thought probably ERIC database would be the good database to use because it's multi-center, prospective, biracial cohort study, and enrolled more than 15,000 participants. And it has 4 different communities, and they follow them serially every 5 years, with the last follow-up was in 2013, but they have also a yearly follow-up. Our inclusion for this study were every participant who were available or attended visit 4. And our exclusion criteria were if the patient has or participant has an AFib or has a stroke at visit 4, they were excluded. If they have any missing CHA2DS2-VASc variables, everybody are familiar with those, and race other than white or black. In ERIC study, the diagnosis ascertainment is done by using, especially in AFib, the AFib diagnosis was ascertained by using ICD codes and ECG performed during visits and also after patient discharge from the hospital. So it's very strongly ascertained. And the stroke was ascertained also using ICD codes, hospital discharge summaries, and also visit summary. And all these strokes has been adjudicated by a separate physician by going through MRI and CTs. So it's a very solid and reliable database to use to study these two important hypotheses. So our statistical analysis, number one, time to prevent and to event analysis was used to study the association between CHA2DS2-VASc score and risk of stroke. And follow-up time was used from the time of inclusion, from baseline to occurrence if either stroke, death, loss to follow-up, or end of follow-up, whichever happened first, and also patients who were initiated on anticoagulation during the follow-up period were censored. We divided our cohort to 5 groups based on the CHA2DS2-VASc 0, 1, 2, 3, and 4 and more. And we calculated incidence rate difference and incidence rate ratio in both AFib and non-AFib in each CHA2DS2-VASc category. And we did also competing risk analysis to accommodate risk of death. And finally, we did the C-statistics. We spoke about it today to study the discriminatory property of the CHA2DS2-VASc in AFib and non-AFib population. So let's go to the results and find out what we found here. Let's go through the inclusion or study diagram. All participants who were at visit 4 were close to 12,000 participants. Almost 1,000 patients or participants were excluded because they did not meet the inclusion criteria. They met the exclusion criteria. That left us with more than 10,000 participants, of which more than 1,300 developed AFib during the course of follow-up. What we did, we matched each AFib individual with 3 controls. So that left us with more than 1,300 AFib patients and more than 3,700 of controls. This is the table that shows you the characteristics of the patient with and without, based on AFib status. On the right side, you see the AFib, and the middle column is the patient with no AFib. We try to match these cohorts based on age, plus minus 5 years, calendar year, race, and gender. As much as we can, also we applied the matching for the CHA2DS2-VASc score. This is one of the, I would like to bring your attention to this table. This is one of the, kind of summarize most of the findings here, that talks about the stroke incidence in participants with and without AFib based on CHA2DS2-VASc score. So starting with the patient with the cohort who has no AFib. As you notice here, the crude incidence rate goes from 0.4 all the way to 6.3. So there's an increased incidence of stroke on patients with no AFib. But however, as you can see here, this is a very low incidence rate because this is based on per 1,000 persons. So this is translated into 0.6%. When we compare that to the AFib cohort, it starts at 12.0 and goes all the way to 72.1. So even patients or participants with 0 CHA2DS2-VASc score, by adding AFib, their stroke rate is really high. To do the incidence rate ratio and incidence rate difference, we have, it also has the same signal from 11.6 all the way to 65.8. So there's an increase similar to what we have seen in the past studies, increased signal or increased risk of stroke as the CHA2DS2-VASc goes up. Then we did to accommodate the competing risk of death, we calculated the absolute risk using the Johansen study method, and also for the relative risk, we did a different calculation. So this is translated into the absolute risk of stroke at 1 year follow-up for a patient with AFib and without AFib. The open circle is the normal population without AFib, and the dark circles are the patient with AFib. And this is, again, the same thing we see in the relative risk. When we did the follow-up over the course of 5 years, we have the same signal. There is an increased risk of stroke in patients with AFib and also in patients without AFib, but the incidence rate of stroke is really low in patients without AFib. Finally, we did also follow up over a course of 10 years, and the signal still showing the same, increased risk of stroke, increased incidence of stroke. The C statistics was kind of modest, 0.64 to 0.60 in patients with and without AFib. As Dr. Madeline Kay described today, it's kind of in the modest, but this is kind of considered this is considered a very good predictor in general. So what is the key findings of our study? Number one, CHA2DS2-VASc score associated with increased risk of stroke in patients without AFib. And the absolute risk of stroke is really low, even with high CHA2DS2-VASc score in people without AFib, as we can see 4 and plus CHA2DS2-VASc. However, in patients without AFib and CHA2DS2-VASc of 0, the risk of stroke is really high. There's limitation to our study. First of all, is that most is the misclassification of AFib. This is subject to error. Probably we missed few participants who had true AFib, and probably people have been mislabeled as AFib, but they have different rhythm. In conclusion here, I would like to have 2 take-home messages. Number one is CHA2DS2-VASc score can only be used to guide anticoagulation therapy in community dweller without AFib, cannot be used. And second, and this is kind of a hypothesis generating point, higher stroke risk in people with AFib with no other risk factors suggests there is something specific about AFib per se, and not the vascular factor as suggested by previous study that increase the risk of stroke. I would like to acknowledge the grants that supported this project, and thank you, and open for questions.
Questions for Chad? I think it was a great presentation. What I would say is between now and then, this is my season, but with, depending on the size of the road, maybe parts of the people in the state, the colors like white, green, black on there, they're very hard to see. So, it's not just a very simple, black on white, and people, and pretty much for any of the things that are being edited, keep the font larger so if they're going to be listened to, they're going to be listened to.
Thank you. Good point.
Some of the no AFib patients, participants may have also had undetected AFib with brain monitoring. I doubt it, right?
Yeah.
So those numbers might, different might be even greater.
Exactly. We might be not capturing or even capture. People has been in intermittent or paroxysmal.
How does the non-AFib CHA/VASc rate, event rate, correlate with other studies that have looked at similar questions in the European model? That, to me, that would be something interesting to potentially show if you could get some, if you could show that data, and where your data lined up.
Yeah, very good question, Matt. This is the incidence rate in general of AFib in that cohort, in the ERIC cohort, has been 12.7%, which is close to what has been published before. But surprisingly, the rate of stroke is a little bit higher, especially with the lower CHA/VASc in our study. Again, it's either because of including a longer follow-up period or because we are following people for almost 10 years that we have some kind of inflation in the incidence rate. But I tried to compare it before, and it's a little bit higher than compared to other studies.
What is the central core message?
Patients with no AFib, and even very vasculopathic, patient who has cabbage, peripheral vascular disease, they don't still qualify or don't, the anticoagulation is not justified in this cohort because the incidence rate of stroke is really low.
I think that needs to be articulated slowly and carefully. Maybe think about the way you want to say that, but in the finish, at the end of the talk, there should be a central message or a core message that people take away. And I think it's useful to slow down when you come to that and look at them in the eye and sort of say, the central message is, you know, and then slowly articulate it without any mistake.
Yeah, yeah.
Other questions or questions about the data? Bob? Very nice. Very good. Thanks.
The aim, yeah, it's we kind of first of all we put the background, what has been known already, and then we started to study the aim of our study, and then I just put a slide for the hypotheses, and then we kind of, as you see here, we rejected the hypotheses for one and accepted the other. But I agree with you, there might be some redundancy in these two. Yeah.
Then what is the central core message here?
So it's actually in the conclusion slide, right?
Yeah.
Which is, although at best for giving stroke risk in people without AFib return possible, the absolute risk of people with stroke is very, very low. Even in those with the highest CHA/VASc score, such that this risk score cannot be used, you know, to recommend conditionality.
That's the message. You hear that? Anything else before Ryan takes the podium?
I think to ask, but even if there was an increased risk, how do you know the anticoagulation is the correct treatment anyway? You're saying it as though there's a thromboembolic risk versus an atherosclerotic risk. So predicting risk is different than knowing the treatment is effective, right? Unless you
It's been proposed by different studies. I mean, we're just trying to show that it's probably not the right.
And then it might, I think Alan's point is well taken, and this would be between you and Lynn, but sometimes it's helpful when you start to tell the audience why you did the study. I mean, you could say, you could even cite a reference quickly and say, it has been suggested by experts that we ought to consider anticoagulation in this population. Therefore, we decided to study a large cohort, et cetera. Kind of sets the stage a little bit. But it's a nice piece of work. Good job. Ryan. So Ryan has an interesting title. Half of, presumably all, in final ICD in patients who undergo cabbage. Half of those patients improve their ejection fraction above 35% cardiovascular. So it's kind of a provocative title.
Okay. So, first of all, this is a poster presentation, but I'm happy to take as much criticism on the slides or the overall talk as possible. But the slides are all black and white and kind of boring. So Dr. Flory was my mentor on this, and I had help from Jessica Boyd and Dr. Adebog and Kyra. Okay, so the background of this is currently patients who are eligible for ICDs that are about to undergo bypass surgery, it's currently recommended that the ICD is not placed at the time of bypass surgery, which would be convenient, right? If you're going in for bypass surgery and you're eligible for an ICD, why not put an ICD in at the time of bypass surgery? However, the current guideline recommendations say that if somebody needs a primary prevention ICD and is undergoing coronary artery bypass surgery, that you still have to wait the usual 90 days prior to having the ICD placed. These guidelines were based largely on a randomized control trial called Cabbage Patch, and what the Cabbage Patch trial looked at was, it was a primary prevention ICD trial looking at patients with an ejection fraction of 35% or less and who also had abnormal EKGs by signal averaged EKGs. So it was a presumably sick population with a high mortality and event rate. However, the results of that study were negative, that putting the ICD in did not reduce mortality. So that was obviously the cause for speculation, and the authors concluded that there may not have been a mortality difference because of perhaps bypass changes the autonomic input to the heart, or perhaps bypass surgery reduces ischemically triggered arrhythmias. What they didn't look at were changes in ejection fraction, because they didn't have echocardiographic data, presumably after bypass surgery. Most people, everybody had echo or some form of EF measurement before the bypass, but they probably lacked that data after the surgery. So there's been additional data that showed that, and this is from subgroup studies of the major ICD trials, that also showed that implantation of an ICD, even up to 18 months after bypass surgery, did not confer a mortality benefit. And once again, post-operative echo data is very limited in these studies, so what we hypothesized was perhaps the absence of a mortality benefit with ICD and Cabbage Patch and some of these other subgroup analyses was due to a perioperative improvement in the ejection fraction for many of the patients, of course not all the patients, but and there are studies that do show that patients improve their ejection fraction as a group with bypass surgery, somewhere between maybe 5, 10, 15 percentage points on their EF. So what we sought to do was to determine the incidence and predictors of EF improvement with bypass surgery. And we were mainly looking at people that improved to above 35%, because that's the threshold that is used by the guidelines in terms of an ICD indication. So we're looking at, we're going to start with people that were below 35 who improved to above 35, whether that was improved to 55 or improved to 36. So we just wanted to see how many people got above 35. So at the VA Medical Center, Dr. Adebaug has a bypass surgery database, and we went through that entire database, which consisted of 2,800 plus patients who underwent isolated bypass surgery without any valve surgery. And that database spans from 2001, and we looked up to December of 2014. We were able to find 375 patients that had an echocardiogram before and after bypass surgery, and we're limited by the number of patients that have a post-operative echocardiogram. So almost everybody going into bypass surgery has an echocardiogram or some form of EF assessment. However, after bypass surgery, there's very limited numbers, and that's because a lot of people do good. People that have bypass surgery, they tend to do well afterwards. Now, of the 375 people that had both pre and post echocardiograms, we looked at patients that had an indication for an ICD for primary prevention, so the group that had an EF of 35% or less, and we found 74 patients. So we had 74 patients that we included in this study. And in the table one, this is stratified by patients who improved. How do I get rid of this? Okay, so stratified by patients that improved post-operatively to an ejection fraction greater than 35% in this column, and in this column are patients that were unchanged, so those who did not get above the threshold of 35. In terms of predictors, the only predictor that we found out of these characteristics were preoperative ejection fraction. So in the patients that improved, they started with a higher ejection fraction, and the patients that never got above the threshold had a lower ejection fraction. There was maybe a trend in patients who had better renal function, so there was a trend suggesting that better renal function may predict improvement, but the p-value was not significant. And something with ACE inhibitors somewhere right here. So people that were on ACE inhibitors trended towards there being improvement, but again, it wasn't statistically significant. Here's the magnitude of change in LV ejection fraction post-revascularization. So now we're again dividing it into this group that got above 35%, patients that will no longer be eligible for ICD, and their pre-op EF was 30 compared to the other group who had a lower pre-op ejection fraction, and the group that improved from 30 to 46, and those that didn't improve 26 to 26. Now, one thing we tried to do was figure out, is there a certain threshold? If your EF is very, very low, are you not going to get above 35? And what we found when we stratified, so here we compared two groups. One was a pre-op ejection fraction of 26 to 35, and we compared it to a pre-op group that was less than 25. And we did find that there was an odds ratio of 5, showing that if your ejection fraction was 26 to 35, your odds ratio would be 5 that you'd get above 35. And then in the group that was less than 25%, it was much less likely that you'd get above 35. However, some of those patients still got above 35, so it can't be a be-all, end-all. You can't just say, okay, you're not going to get above 35. There's no way of predicting that. So, okay, so in the Cabbage Patch trial where patients were randomized, there was no difference in mortality between getting an ICD at the time of bypass versus not doing that. And we hypothesized that the absence of mortality may be because of improvement in LV function in many of those patients. We found that of the 74 patients we looked at, just over half of those patients improved to above 35. So our findings support this hypothesis that perhaps an improvement in ejection fraction is the reason that patients don't benefit from an ICD at the time of bypass surgery. And it seems like a reasonable hypothesis, and our data does support that. So in conclusion,
we said that over half of ICD eligible patients before bypass no longer become eligible after bypass. And these results do support the current guidelines, which say to wait, to not put an ICD in until at least 90 days after bypass surgery. And the final conclusion was that EF improvement was much less likely in patients who had an ejection fraction less than or equal to 25 at baseline. Take any questions? Kurt?
So did you see any difference in ICD firing rates between your two groups? Mine that data?
So of the 74 patients, we're still gathering the data on who actually has ICDs. So post-operatively, I don't know how many patients actually have ICDs. Matt?
How many patients went in with a depressed yes that didn't get a follow-up? So you're looking at the recovery. What percentage of these 2,000 patients had EF below 35 that didn't get a subsequent follow-up?
Yeah, that's a good question. So right now we're actually going back and we're getting all the pre-op EF because it was so hard to get data on 2,800 people. So to simplify things, we started with looking at who had a post-op echo, and we found, like the 375, assuming they'd all have pre-op echoes. So now we're actually going back and we're looking at the rest of the database and getting pre-op EF. So we have none of that data. It's a very small amount that had pre and post echoes. It's only 8% of the entire CABG database. So this is a very selected population. So this is all just hypothesis generating, of course. Dr. Shadai?
Did you use clinical reads or did you have other like we find it without?
Right. So the clinical reads, that was one of the reviewer criticisms, and they asked if we had reread these.
There's a lot of inter-study and inter-observer variability with echoes, so depending on the patient, anywhere from 5 to 15. That may explain some of the. Also, that may explain why you found that the ones who had like relatively high EF to begin with.
Mm-hmm.
So, variability of 5 to 10%, sometimes the EF.
Right. Right. Dr. Berger. Mm-hmm. Mm-hmm. Sure. Got it. Mm-hmm. Great points. Thank you. Any other questions?
Okay, if not, thanks, Ryan.
Thank you.
The last presentation is by Justin. And she's going to speak about cardiac arrest after cardiac surgery is associated with high in-hospital and long-term mortality. Our mentor is Dr. Adabak.
Yeah. Hello, everybody. As Dr. Francis just said, and by the way, this is also a poster presentation at AHA, so put the slides together last minute. But as Dr. Francis just said, we took a look at cardiac arrest after cardiac surgery, specifically looking at the long-term outcomes of those patients. And a tiny bit of background information that's relevant. No surprise, but cardiac arrest is a very grave complication or feared complication after cardiac surgery. Literature reports that the incidence of this is between 0.7 and 5.2%, and a case fatality rate anywhere between 30 and 80%. We'll get to our data in just a second. Perioperative MI is often reported as the cause of most cardiac arrest, but other things like tamponade, or graft or prosthesis malfunction, ventricular arrhythmias, aortic tears, things like that are also reported to be causes of cardiac arrest. And the short-term mortality is very high due to things like renal failure, sepsis, anoxic brain injury. But prior to our study, we didn't really find anything that reported the long-term outcome of those patients who survived cardiac arrest and survived to hospital discharge. So as you can imagine, this was our objective, was basically just to investigate the long-term outcomes of those who survived cardiac arrest after cardiac surgery. And to do this, similar to Ryan's research project, we examined the cardiac surgery database that's kept at the Minneapolis VA, and this included 6,979 consecutive patients going all the way from 1991 through December of 2014. And of this, we found 182 cardiac arrests, so thankfully not too many. And the important things to know about this database are that they collected info on the demographics, pre-op imaging, clinical values, lab values, and then the post-op outcomes. And the post-op mortality was recorded at 30 days, 1 year, and then long-term. And our patient population, no big surprise for the VA. And I have those with a little bit tough to see. But this is the patients who don't have cardiac arrest, so 6,797 patients, and those who do, 182. And the population was mostly males in both groups. But as you can see, just starting here to look down the column of patients who had cardiac arrest, they are a little bit sicker with a New York Heart Association class 3 or 4 heart failure and with a lower ejection fraction than their colleagues. And they also had a little bit more complicated surgery, meaning some of them had had prior cardiac surgeries, more of them had a non-elective surgery, they had a little bit longer cardiopulmonary bypass time, and more of them needed a pre-op intra-aortic balloon pump. So they were probably sicker going into a more complicated surgery. More of our results. The majority of cardiac arrests occurred within the first 3 days, so this was our median, and 51% of cardiac arrests occurred within the first 3 days. There was one that had already lasted into day 30 of that hospitalization, but that was an outlier. The majority happened up front, and many were, as you can see, many were on the very same day as their surgery. Some additional results. This was the type of cardiac surgery in patients with and without cardiac arrest. So CABG right here was the majority of patients, and this was CABG without any other associated procedure. And they actually had sort of the lower or lowest incidence of cardiac arrest in comparison to those who had CABG plus some other surgery or some other surgery. And this other category down here includes things like ASD or VSD closures, an anomalous coronary artery repair, or something structurally related, I guess. Some additional results. So here is kind of the meat of our data. So at 1 year of follow-up, 24 patients, at one year of follow-up, 24 patients had already died, and that was after this in-hospital incident of death that was 51%. So 51% died right away. Another 24% died within the very first year, and that's in comparison to those who don't have cardiac arrest. So this was significant. And then getting at the long-term follow-up down here, our average follow-up was about 7.5 years for these patients, and the long-term mortality rate for those who had cardiac arrest versus those who didn't was 81% versus 34%, and that was also statistically significant. When we adjusted, however, for age, sex, and the year that the surgery was performed, having an in-hospital cardiac arrest was associated with a 4.7 times higher incidence of long-term mortality in the whole cohort. And then if you look at a 30-day outcome there, the incidence is the risk is 2 times higher for long-term mortality. And if you go all the way out to the long-term follow-up, the mortality is 1.3 times higher, which was not statistically significant, but trended towards significance. So you can see these curves do still deviate, but not statistically significant. In multivariate analysis, we were trying to look for some predictors that would help figure out which patients are going to do worse if they survive to hospital discharge. And not too much of a surprise, also discharging to home was much better than being discharged to a facility. And if you left the hospital with abnormal kidney function, that was also a sign of a worse outcome in the long run. And then the last piece of data that I just wanted to share was we were sort of curious in CPRS, which is our computer system at the VA, came into effect in 2001. And only those patients after 2001, we were able to extract a little bit more data about the details of their cardiac arrest. So we have a little bit more interesting data about just 105 patients that occurred after 2001. And the interesting thing here is, I guess, the non-fatal cardiac arrest versus fatal cardiac arrest. Much more of them were VT or VF, and they all got defibrillation. And it's not too much of a surprise that those are the patients who end up doing better in the long run. The last interesting piece of information was that 11 patients who survived cardiac arrest discharged from the hospital with an ICD during that same hospitalization. And none of those patients ever needed their ICD. Only one had an inappropriate shock, but all the rest never had an appropriate shock during follow-up period. So our conclusions is that cardiac arrest is not good after cardiac surgery. Long-term mortality, in addition to short-term mortality, long-term mortality still remains high, even if you've discharged alive from the hospital. And potentially discharge disposition and renal dysfunction could be used as predictors of those people who will experience long-term mortality. I think that's it. And I will just acknowledge Dr. Audubon, who spends countless hours with me, Dr. Vakil, and Chadi, and Dr. Ravindran for letting me go to AHA. Yeah.
Can you go through the slides from the beginning?
Yeah.
These are familiar themes that are coming up over and over. So, one of the things that should come out of the aspect is that as you're following very logical fashion, there should be no surprises. So, if you're presenting data that really wasn't expected to see in the beginning, it should be part of your message. So,
okay.
Nice slide, go forward. So, background, I think overall was very nice. You should have a hypothesis slide where it simply states what you're trying to do with your data, and it should happen after the background. The background should lead into the idea of why you're doing it, what is not out there, why are you challenging the existing body of literature, what more are you trying to learn, rather than putting the objective and message together. And then the message should line up with, and it only needs to be a simple idea, but for you, it's going to be exploratory analysis, that you're going to separate the cardiac arrest from non-cardiac arrest, you're going to do a proportional hazard analysis, you can do a multivariate analysis, and then maybe the last one, which you didn't mention until near the end, is that in those patients for the last 10 years in that greater detail, you're going to do a deep, in-depth analysis to find out more about people. So patient population, I think you did a nice job here. Once again, I'm just saying this, I'm not sure if the University of Minnesota is referring to you, but if you're stepping back from here, I'm not the right level, but black line burgundy, like black line green is going to be hard to see. And somebody who's going to look at this, the most important thing they're going to want to know is what's the difference between the left and the right column. If they don't know who's got the cardiac arrest and who doesn't, they don't know how to interpret anything. Because, so one thing that would be very nice for this is to show a cumulative incidence. So on the right axis, go from 0 to 100%, so it's a different axis, and show a curve that's going to go something like this. So people get an idea of where it's happening. What you're going to see on a curve like this, which makes sense, is that people have cardiac arrest, there's a big jump in the beginning, and then it comes back and out.
Yeah.
But as you discussed this, I have a hard time to, first I wasn't expecting the right slide to come to the left, because first I thought you had an expanded it. But the impression I got when I looked at the right, not seeing any two values, it really wasn't that much of a difference, but you indicated initially something like a four-fold increase. So I'm not sure if I can see what you were saying from that slide, or I'm misunderstanding.
Yeah, I agree.
Okay.
This is a critical slide. It was a little confusing. It looks like actually once you survive 30 days, the rate of death is about the same. because the slopes are pretty similar, and I don't know if you made that point clearly or not. So.
Okay.
And in
I'll work on that.
particular, I think one of the important things is that if I'm looking at this, if I had a cardiac arrest in the hospital and I'm alive in the hospital, I'm particularly interested in whether or not after I go out, I'm going to be alive. I'm assuming that that blue line is in hospital. It may be important to identify, or some people would take the graph and explode it and show this is the point afterwards. This is probably where that blue line becomes curvilinear of what's happening to the point. It's just an important thing because, you know, if you're out, if you don't make it out of the hospital, then it doesn't matter, right? But for those people who make it out of the hospital,
Okay.
this one, I think it was more like the chicken and the egg thing. So I would say that the reason that people went to the rehab and nursing home, and I'm not saying that conversation, but if they're dead at the end of the angioplasty and borderline on event, I'm not going to send them home to be with it. So this is kind of, I don't think the information goes correct, kind of this myth. I do think it's really important, and you mentioned it, and I heard you say that I couldn't function, but I think the thing that's very important to learn from your data is what are the predictors or what identifies that people are alive with success. So you should have applied from your logistic regression or somewhere tabulated so that people know, oh, for people like cardiac, maybe it was the intubate less than 30 days, maybe it's they had beats in the hospital, but what were the things if you have them, they allowed you to identify who's alive and not alive. That's really what's going to lead you.
Okay.
That's good. I'm just trying to give you some ideas of
That's really helpful.
What to do and to keep it clean, but in particular, people lose interest in the linear relationship. So, you know, the first thing they do is they want to see, and I like how you actually identified, instead of asking questions, you actually did a statement, and it's a very unique way of doing it, and I'm not sure if that was your method, that's fantastic. But the next 2 or 3 slides are very interesting. So, and I think some of the other fellows in the same thing with the background. You don't want to spend too much time on your background, because this is really your presentation, not a review of the literature. The background should really be kind of synopsis. It's a highlight, maybe 2 or 3 points leading to why you're doing your work. And it's particularly important on the following slide about your hypothesis, and then for your methods to be very clean. And theoretically, each one of those goals for your methods is going to lead to a slide which is an aspect of the results, and limitations to treatment. Setting them up.
Thank you. You can ask me later.
Other questions, Kurt?
How is your survival in these people compared to anybody else, like somebody who coded not having cardiac surgery, same survival?
I mean, the cause of cardiac arrest is so wide, it's a little bit hard to make that comparison. At least our data did match what's previously been reported for the incidence and the mortality, in-hospital mortality of cardiac arrest, but it's a little bit hard to answer that question, I guess, because the circumstances of the surgery are a lot different than, you know, anyone else who codes in the hospital.
Okay, I'd like to.
Are you working on paper?
Yeah, under review.
I'd like to thank all 3 presenters. You all 3 did a very good job, and we'll see you down in Orlando. Thanks for coming, everybody.
Sometimes I think
I know. Yeah. True story. Real email, real text. And then, the punchline was, scoop it, all within like 5 minutes. 5 minutes. I'll take 3 minutes. Yeah, it was awesome. And he delivered it so well too. I guess right now. All right.
Yeah, I just got a review back. I mean, it got declined by 2 journals already, but I just got a review back from Annals of Thoracic Surgery, and that sounded very optimistic.
I think I come out left field. So the body has three cavities. One of them is the thorax. And the thorax is the heart.
Hey, you gotta start in the funnel, right? You gotta start wide.
Many animals have hearts. One kind of animal is human.
They're on cover team. Let me help you.
I was like trying to give him as much like as many encouraging gestures and nodding as possible, so he can move quickly. Yeah, that's great.
He actually just used me with an arrow for that second, that last line, like. I was telling you, when I looked at.
I also wanted him to put people on the EG again. I wanted him to hit people on the EG now.
Yeah, because that's way harder to give it as a first hero than.
You know, like, he could have done that.
Oh, your name was read aloud by me.
You're in good company.
Yeah. Half the social. It'll list who has not sent the list. Oh, you were on that. I was like. Uh-huh. Yeah. So, BAYE'S, I didn't realize. That's the factor of 98. Yeah. Absolutely insane. I didn't work more than 98%. Because getting from 98 to 100 is really a hard thing. You need to get 2 more papers as decided to 100. You write a paper.
Or cite all of your own.
Yeah, cite all of your own. That only comes with 1. I'm like, yeah, 99 more. I got 1. I send my own paper.
It built up, right? The first one you said one, the second one you said two, the third one you said three.
No, but, you know, for example, if you have two guidelines here, right, and someone is cited twice, you might be cited 1,000 times, but you, that's a chapter. Cool? Yeah. Yeah, if you have like two papers.
I'm a volume.
All right.